Okay, so we're going to pick up tonight with cardiac emergencies, building upon what we talked about the last night with the respiratory emergencies. So let me just let these people in. Okay. And then the Wednesday night, we're going to start pharmacology. So today I sent out the PowerPoints for the pharmacology class and also some handouts I made where they go into each medication in some detail. So everybody should be getting that. Somebody asked me to share the Dropbox and I completely forgot. So I'll try to remember to do that either after the class is over or tomorrow. Just if you're on now, just remind me because I completely forgot to share it with you. Okay, so let's do a quick review of the anatomy and physiology of the heart. So we know that the heart is the pump of the cardiovascular system, and it's pumping fluid called blood through tubes called blood vessels, right? And the blood, we said, has four components to it. I'm sorry, the blood has, yes, four components to it. It has the plasma, the fluid portion of the blood, and floating inside the plasma is what they call the formed parts, the parts that have shape to them. And those are the blood cells. And we have red blood cells, white blood cells, and platelets. And amongst the many functions of red blood cells, the one we mainly talk about is the transporter of carbon dioxide and oxygen, and that the oxygen is transported by the hemoglobin molecules, right? And that the white blood cells fight infection, and the platelets help in the clotting or making, stopping bleeding. Okay, so that's it. And that as far as the blood vessels go, we said that there are arteries which bring blood away from the heart. They're typically high in oxygen. And everybody at this point should know that the only artery that's low in oxygen is the pulmonary artery. And that's because the pulmonary artery starts on the right ventricle and at the right side of the heart receives deoxygenated blood, right? It's from the superior and inferior vena cava, comes into the right atrium, right ventricle. So that's all low. And then it goes out into the pulmonary artery, and the pulmonary artery splits into a right and left branch, going to the right and left lungs. So this artery, even though it's an artery, and it's only called an artery because it goes away from the heart, arteries always go away from the heart. It's a artery that has low levels of oxygen because it's coming from the right side of the heart, which gets the deoxygenated blood from the body. And then, one second. Okay, and then we have at the end, the arteries get smaller and smaller and smaller until they turn into capillaries. Capillaries, we said, are the thin-walled vessels, so small that we can't see them with a naked eye. We need a microscope. And that the walls of the capillaries are so thin that they allow substances to travel across the walls. And that's how we get the nutrients from the bloodstream into the cells, and how we get the waste products out of the cells into the bloodstream to be circulated back to be gotten rid of, right? The waste products always have to be removed from the body. And then on the way back from the capillaries, after they've done what they need to do, we have veins that bring blood back to the heart. We said the large artery that they're going to ask us on the test is the aorta, okay, which starts off the left ventricle, and the left ventricle actually pumps upwards, okay, and then the aorta arches, comes behind the heart. You see a little bit of it here, travels down in front of your spine till about probably your belly button, maybe just a little lower. And then it splits into your iliacs and down into your legs. It becomes your femoral veins, femoral arteries, and so on. And then off the arch of the aorta are three big blood vessels. You can only see two of them here that bring blood up to your arms, shoulders, head, neck, brain, etc. Okay. This one is the superior vena cava. This is the inferior vena cava, which are the big veins that are bringing blood back to the right atrium. And then you could see four pulmonary veins. Those come back from the lungs, high in oxygen. Again, these are the only veins that are high in oxygen because they're coming back from the lungs into the left atrium, to the left ventricle, to the aorta, and they're pumping the oxygenated blood all around. Remember, your upper chambers are called atriums. Your lower chambers are called ventricles. They're going to ask you what's the thickest, strongest chamber of the heart, and it's going to be the left ventricle. You can see how thick the wall is, and that's because it has to pump the furthest. And the thinnest are the atriums. The right side of the heart pumps to the lungs, left side pumps to the body. And then there's always a test question that says, what blood vessels are in close contact with the alveoli of the lungs, or they may just say with the lungs. So the blood vessel that's in close contact with the alveoli of the lungs are the pulmonary capillaries. And again, what happens is you have the pulmonary artery bringing the deoxygenated blood towards those alveoli. At the time it gets down to the level of the alveoli, it's already changed into capillaries, because we know that the blood now has to exchange between the capillaries and the alveoli. In this situation, since the blood is low on oxygen, it's giving carbon dioxide into the alveoli to have the patient exhale it, and it's taking the oxygen that's in the alveoli, bringing it into the capillary, which is going to bring it back into a pulmonary vein, and eventually make it all the way right into the big pulmonary veins, back to the left side of the heart to go to the whole body. So that's kind of circulation in a heartbeat. Does anybody have any questions on the circulation part of the heart? Any questions on chambers, blood vessels, anything like that?
Where does when the blood gets cleaned, when does it go into the kidneys? It goes
good question. As part of the traveling through the body, it passes through the kidneys. I don't know, obviously it's an artery, so it's going to be the aorta, and there's renal arteries off the aorta, probably, down pretty low, because it's in your lower back, that bring blood to your kidneys. There's what they call a hepatic artery that brings blood to your liver. There's a splenic artery that brings blood to your veins, but all the big arteries either originate off the aorta as it travels down your back, or originate off another large artery that came off your aorta, because all arteries, if you trace them back, have to come off the aorta, because that's the first big blood vessel.
Yeah, but what I'm asking is, it's not like it's only a one way. All the blood goes through the kidneys and then it goes around. It goes to certain places and it just keeps on cleaning some of the blood the whole time. So
yes,
basically it's not like every time the heart pumps, it goes right through the kidneys and then it goes to the rest of it.
No, picture it like being a hose, like you have the filter, you have the pump pumping into a hose, right? That's a big circuit. And then off the hose, there's other blood vessels. So you're right. It's not like every time it's going, every ounce of blood every time is going to the kidneys. But yes, there's a lot of blood going to the kidneys and the liver. And, we could look it up, how many liters of blood per minute travel through the kidneys, and how many liters of blood travel through the spleen and the liver. But I would assume, that there's a significant amount of blood going through those organs, because when they're injured, they bleed a lot. So, I would think there's a significant amount going through pretty much, all the time. Okay, so let's read some of the questions. It says, the blood going upwards to the brain and head, do they go back to the lungs right after without going through the rest of the body? So that's a good question. So the blood that's going up to the brain comes back down. So like you have a carotid arteries bringing blood up to the brain, okay? And then you have veins bringing blood back down, and they empty into your subclavian artery. Okay, well, first not just subclavian artery, subclavian vein. First they go into your jugular vein in your neck, then they go down into your subclavian vein, and then it goes right into the superior. Let me go backwards a little bit. It goes, hold on. So as the blood it went up via these three blood vessels up to the brain. Once it finishes what it needs to do in the brain, it comes back down veins, which empty into the superior vena cava right into the heart. So no, it's not traveling all the way. So everything above your nipple line is basically coming right into the superior vena cava and emptying right back in. And everything below your nipple line is going to come back up eventually. It takes longer, right? Because it's a longer journey. Come back up into your inferior vena cava, this blue one down here, and empty into your right atrium. So that's a good question. What else do we have? From the left side, back from the lungs, does it go to the left atrium? Yes. So when the right side pumps to the lungs, when the lungs bring it back to the heart, they go into the left atrium, then left ventricle, then aorta, then to the body. Okay, so right side, right atrium, right ventricle, into the pulmonary artery, to the lungs. Once the lungs do what they need to do, it goes from the pulmonary vein back to the left atrium, left ventricle, aorta to the whole body. Okay. Let's see, related to the above question. If they don't travel back through the entire body, how do they get filtered through the kidneys? So again, it doesn't have to specifically be that that ounce of blood that went to the brain that time is going to be the same ounce of blood that goes to the brain the next time. So, you know, it's just fluid traveling through a pump. So eventually all blood travels through the brain, all blood travels through the kidneys. In other words, all blood has to get cleaned. So at some point, some of that blood, right, it's fluid. You know, if you had a pool, right, and the filter is circulating the water in the pool, eventually all that water, okay, goes through the filter. It may not be, you know, at the same time as certain parts of the water, but eventually everything does go through the through all the cleansing organs. What else do we have? The screen is different from usual. We can also see your next screen slide. Okay, so I can change your view. I told you I got a new computer and I'm, let's see.
Perfect.
Is that better?
Yeah, it's normal now.
Okay. Yeah, when something's not right, don't wait to, you know, interrupt me. Don't wait to tell me. Now I can see you guys again. Let's see who's playing on their phones and who's dozing. Okay, let's see what else we have. Okay, no, okay, so it worked. Okay, so that worked. So any questions on the anatomy and physiology of the heart?
So I have another question. I don't know if we could explain it exactly now, but what happens by systolic and diastolic? What happens to the heart, and why would I get a different reading on the, like,
Okay.
why does the systolic go up and why does it go down?
Good questions.
And,
yep.
okay.
So the systolic is the pressure in the arteries when the ventricles are contracting. So for a ventricle to contract, a couple of things has to happen. Now, we don't talk about all these little structures in here, but there's valves between the atriums and the ventricles. And these are the ropes that open and close the valves. Okay, that's what you're looking at here. There's also valves between blood vessels, right? So there's a valve here, right? There would be valve, you can't see them all, but there's valves everywhere, right? There's like, this is the valve into the aorta right here, because that's going to pump into the aorta. So the first question is, let's say what happens in systole. In systole, the ventricles contract. So I guess let's just go backwards. You know that both atriums contract at the same time and push blood down to the ventricles. Okay, so for that to happen, the valves between the atriums and the ventricles have to open, right? So the first thing, so we're going to move blood from up here to down to here. So what's going to happen is these valves have to open between the atriums and the ventricles, and the valves at the ends of the ventricles, so in this case, it's the right ventricle, the pulmonary valve has to close, and the aortic valve has to close, so that blood just fills up in here right now, okay? And it's not going anywhere. Once the atriums have completely emptied by gravity, by just opening, okay, they actually squeeze a tiny little bit and push the rest of the blood down. Once they finish squeezing, they close these valves. Okay, now remember, this is like chop chop. I mean, I'm talking slow, but you know, if you have a heartbeat of 60 beats per minute, that's every second that the, every second that the, you know, it's doing all of this. So you're talking half a second to probably move blood from here to here and another half a second to pump it here. So now we got blood, we got filled up. I got to talk a little lower. My son's studying. We have filled up ventricles. If you don't hear me, just let me know. We have filled up ventricles, and we want that blood, that right ventricle blood, to go into the pulmonary artery, and want that left ventricle blood to go into the aorta. So these valves now have to close, right? Because if these valves were still open and this starts to squeeze, it would push bloods backwards. So your bicuspid valve and your your tricuspid valve and your bicuspid valve have to close. Okay, so you see here, it calls it mitral valve. That's just another name for the bicuspid. And here's the tricuspid valve, right? So they have to close. But now, since we want blood to go into these blood vessels, the valves at the bottom of the blood vessels have to open. So again, the valves between the atriums and the ventricles close. The valves to the pulmonary artery and the pulmonary vein open. The ventricles squeeze. The right ventricle pushes into the pulmonary artery. The left ventricle pumps into the aorta. So now the question, what is systole? Systole is the pressure in the arteries when the ventricles squeeze. Obviously, it's the pressure in the left ventricle because we're measuring pressure in arteries, and this is the start of arteries, right? The aorta. So systole is the pumping part of the heart, the contracting part of the heart, the active phase, right? The squeezing part, kind of like what inhalation is to the lungs. And then diastole is when the ventricles refill with blood, right? So when they finish pumping, this valve closes, the aortic valve closes, and the valves, the tricuspid and bicuspid valves open, and the ventricles fill. So they more or less say diastole is the resting pressure, and systole is the squeezing pressure, is the the active pressure. Okay, did I explain it okay, Asher? Yes.
Yes, yes. I want to understand why would it go down? What happens when I see someone has a diastolic pressure, a low diastolic, and why is it going to go up? What happens to the heart in that moment?
You mean
like when someone goes into shock? What changes?
So the first, okay, so let's say early shock, and then I'm going to move on because I don't want to, these are all good questions, but we'll save.
That's why
this.
I said I don't know if we'll be able to.
No, it's
go
fine.
through
It's
all
fine.
of
It's
them.
a good question. So
Okay.
we're going to save. Just remember it, and we'll save it for our review session. Are we going to have class Motzei Shabbos? Because I know it's Shabbos Hanukkah. So you just got to let me know. I don't know if
We
we
can
are.
still have class.
What's that?
We can still have class even it's Hanukkah.
Okay, your wife and kids aren't going to hate me and hate you. we'll
Don't
talk
worry,
about
I'll
it.
handle that.
We could
I'm
talk
handling
about
this
it.
for 9 years already.
We'll talk about it Wednesday night, and we'll figure out for sure. So I've got some yeses, I got some nos. We'll see. Again, if you can't attend, I understand, but I will tape it, so you could always listen to it. So don't get crazy. And I'm not 100% sure what I'm doing, so I'm just throwing that out there. Okay, so the question was what was it again? What happens? Oh, what happens in early shock? So in early shock, you're going to get the changes. You're going to get two changes. You're going to get probably that the systolic, the higher pressure stays the same because the body's trying to compensate. But what happens is because there's vasoconstriction going on because of that compensation, the diastolic blood pressure, the diastole, the lower blood pressure actually reflects, right, the pressure in the blood vessels kind of at rest. So since there's some constriction going on because diastole is rest, the diastolic rises. So let's say we always say a normal blood pressure is 120/80. Okay. So let's say the 120 stays at 120, but the 80 goes to 90. So the pulse pressure is the number between the difference between the systolic and the diastolic. So 120/80 would give us a pulse pressure of 40, right? Because 80 plus 40 is 120. So now instead of 120/80, it goes to 120/90. So you got a pulse pressure of 30. So they say a tightening of the pulse pressure because it's 30 instead of 40 shows you early compensation, because what's really showing you is that the diastolic, the rest, because of the vasoconstriction, is starting to get tighter. But I just be honest with you, that's great that you think this deeply. Again, is what I enjoyed about teaching Jewish classes, but it's not going to be, they'll never ask you at that level on a state exam because there would be no EMT in New York State. Okay. Okay, so now let's talk about how do people have problems with their heart? So yes, it can be genetics. Okay, some people are more prone to cardiovascular disease than others. Okay, but a lot of it is self-inflicted, which means it's our diet and lack of exercise that does it. Okay, and most of the times, problems to the heart start with problems in the blood vessels. Okay, so there's a couple different types of what they call coronary artery disease. Coronary arteries are the arteries on the surface of the heart that give blood to the heart. On the test the other day, it said like where the different arteries or something like that. Well, the coronary arteries start right off the aorta. So let me go back here for a second. Let's see. So the coronary arteries would start basically right here at the base of the aorta, and they bring blood across the surface of the heart, okay, to the heart. So that's how the heart gets its oxygen and everything it needs. So coronary arteries don't travel very far. They're kind of small, but they're vital to keeping the heart alive because those are the arteries that bring blood, to the heart so that it can stay alive. Now, based on our diet, lack of exercise, and other bad things we do, okay, we get fat deposits on the inside of our blood vessels. Okay, when they went back and they found preserved bodies, 1,000 years old, 2,000 years old and stuff, they did not have coronary artery disease, and that's because it was very hard to get meat then, right? I mean, to get meat, you had to hunt, and and stuff like that. So it was harder to get meat, and meat was a treat. So most of the times, they ate fruits, vegetables, grains, and stuff like that. Eating meat is where we get the fat in our diet. Okay. I mean, there are some vegetables and fruits that are high in fat, but for the most part, it's good fat, believe it or not, as compared to animal fat. So what happens is that when we have too much fat floating around in our blood vessels, some of it sticks to the walls of the blood vessels. And when it sticks to the walls of the blood vessels, it starts to clog up the blood vessels. And that's what coronary artery disease is called. So this buildup of fat starts to narrow the blood vessels. Okay, what actually happens is that once that fat starts building up in the arteries, the coronary arteries, the body actually kind of locks it in place with a cap over it. It grows a covering over it to kind of lock it in place. And that covering is actually a good thing, okay? But the issue is that sometimes that covering on the inside of the artery breaks. Okay, we'll talk about that when we talk about heart attacks. And when that covering on the inside of the artery breaks, the body thinks there's a cut or a wound. And we already said that whenever there's a cut or a wound, it sends platelets, right, to try to make a clot, a scab. And what happens if that happens on the inside of the artery, because it's not really a cut, right? It's just a perceived thing on the part of the platelets. If this happens on the inside of the artery, those platelets go and continue to seal off that artery. And once they close that artery off or narrow that artery where there's not enough blood getting through, the heart is deprived of the oxygenated blood, and it changes from aerobic metabolism to anaerobic metabolism. And the person starts getting chest pain because of the buildup of the lactic acid. Okay. So it says when you chest compressions, if the top chambers are not compressing at the same time, which part of the pump? So when you put your hands, if you put your hands in the right position on the chest when you're doing CPR, your hands are over the ventricles, okay? And again, most of the blood that comes from the atrium to the ventricles just kind of comes by gravity. So I understand what you're saying. You're saying that maybe there's not enough blood circulating with CPR, but you have to also remember that when somebody's in cardiac arrest, all those valves are kind of relaxed and open. So you are circulating blood, trust me, or else, we wouldn't be doing it. So you don't have to fear, anything, as far as blood not flowing. The only reason blood would not be flowing is because you're not pushing deep enough, fast enough, or you have your hands in the wrong position. Okay, so the main cause of this coronary artery disease is really the food we eat, high cholesterol food. Smoking also damages blood vessels. HTN is high blood pressure. So the issue when somebody has high blood pressure is that if the pressure in your arteries is high, your aorta obviously has to squeeze harder, right? So if it has to squeeze harder, it works harder. And if your left ventricle works harder, and obviously you don't want every minute of your life that your left ventricle is working harder, because obviously our parts have a useful life, and if we wear them out quicker, we die quicker. The other issue is that all your organs are designed to handle blood going through it at a certain pressure. And when there's too much pressure going through, it damages the organs. So the classic side effect of untreated high blood pressure is that the heart gets big and floppy, and you develop congestive heart failure because it can't pump correctly, and you have renal failure. Your kidneys start to fail because your kidneys get damaged from the high blood pressure. Okay, so that's definitely one of the issues of untreated high blood pressure. Remember, we could all get our blood pressure under control. I shouldn't say all. There's some people that just genetics have high blood pressure that's very hard to treat without medications, but most of us can get our blood pressure under control by walking. Okay, a lot, and you have to walk, figure 5 miles a day, and it has to be brisk walking. In other words, you should feel like it's a little hard to breathe or talk when you're walking, and dropping some weight and reducing our salt intake, right? Those are all the things that would dramatically lower your blood pressure to the point you probably would not need to take medications. The problem is that it's easier to take a pill once a day than it is to have that type of lifestyle. So that's why a lot of people, just take medicine. Okay. Again, high cholesterol from the fatty foods. Diabetes is a disease, and I know we think it's just a sugar problem, but the disease of diabetes actually damages blood vessels amongst many other things. So people who have diabetes are definitely more prone to having problems in their arteries. And a sedentary lifestyle means you're not active, right? You're sitting at a desk all day long. So somebody asked, is the fat buildup limited to the coronary arteries? Great question. I was about to get into that. So you could have fat deposits in any artery, and you could have problems because of that. In other words, it's not uncommon for people to have those problems in the carotid arteries in the neck. Okay. And now they're not getting enough blood up to their brain, or if a piece of that fat breaks loose and goes up to the brain, they have a stroke. So you could have it in any artery of the body. Okay. There's people who have problems with, throwing little emboli, little clots into their kidneys. There's a thing called a fatty liver for people that tend to eat very, very fatty foods where they develop liver failure because of that. So yes, you could have any place in your body, but tonight we're talking about heart problems. Okay, so now when you have this coronary artery disease, you could have two issues. You could have something called a thrombus, or you could have something called an emboli. So a thrombus is that at the site in the artery where the fat is, okay, that's where the problem is, that fat either breaks a little bit and the body sends platelets, okay, or it breaks loose and becomes an emboli. So a thrombus is just a term for the fat stuck on the inside of the artery. Okay, when it breaks loose, it's called an emboli and travels. Now, it doesn't have to just be a fat emboli. It doesn't have to be it could be like a woman could have an amniotic fluid emboli when she's giving birth. It could be an air embolism. There's a lot of, embolism or emboli is the term for something floating through your bloodstream other than blood. Okay, but because we're talking about coronary artery disease, we're kind of talking about fat and stuff like that. Now, the issues with an emboli is that it will travel through your bloodstream until it gets to a blood vessel that's too small for it to travel through, and then it'll get stuck and it'll stop blood flow any further, right? So, that's the issue. Okay, now, I think at one point we talked about something called a deep vein thrombosis, right? So a DVT, deep vein thrombosis, is a blood clot in the lower leg that we said women who are pregnant, people who stand on their feet, people who are heavy are all prone to, and that if it breaks loose, it could travel up your leg, into your inferior vena cava, into your right atrium, into your right ventricles, shoot out into your pulmonary artery and lodge in your lung and cause a pulmonary embolus, right? Emboli, embolus. So you can see how a thrombotic, issue in a blood vessel breaks loose, becomes an emboli, and travels somewhere and causes a major emergency.
Does that have anything to do with varicose veins or no?
Sure. Varicose veins are the side effect of somebody who stands on their feet all day, or somebody who's heavy, or somebody. So once you have varicose veins, you're more at risk to have deep vein thrombosis, because what happens is the veins get all floppy and distended, and there's very little effective blood flow through them. And whenever blood starts to travel very slow, okay, that's when it can clot up, right? All a blood clot is most of the times is blood that's not moving quick enough, or blood that's left the body. But most of the times inside the body, it's blood that's not moving well enough, and it develops into a clot. Okay, so the issue with coronary artery disease, as far as when we start talking about heart attacks and stuff like that, is that when the blood flow in the coronary artery gets knocked out, gets stopped, everything past that point in the coronary artery that has the problem starts to die because it's not getting oxygen. And that's really what a heart attack is. Now, chest pain is the most common symptom when somebody has reduced blood flow. Now, it doesn't have to be that it's completely shut off, because we're going to talk about a medical emergency called Angina Pectoris. We're going to talk about a medical emergency called acute myocardial infarction. So one is a temporary problem, okay? And one is more of a, I don't want to say permanent, because we have ways of fixing it now. So, but anytime the heart muscle, right, the myocardium, the heart muscle, the squeezing part of the heart is not getting enough oxygenated blood, it has to change, right? The metabolism, the burning of the fuel has to change from good metabolism, which is aerobic metabolism, to bad metabolism, which is anaerobic metabolism. And once you have anaerobic metabolism, you have lactic acid. And when you have lactic acid, you have pain. Just remember when you were walking fast and you got a pain in your side, it's lactic acid. So now that pain is in the heart, and it's not going to go away, okay, until you open up those blood vessels. And the only way to open up those blood vessels is to get the person to the hospital to have a procedure called angioplasty. Okay. This is not going to be on the test, okay? But there's different types of coronary artery disease. So there's arthrosclerosis, okay, and atherosclerosis. I know they look exactly the same, but one has an R, the other one doesn't, okay? So the easiest way for me to remember which one is which, and again, you don't have to because it's not going to be on the test, okay, is I put an F in front of this one, and it says fat sclerosis. So this is caused by fat, okay, and this is caused by what they call a hardening of the artery because it takes a long time to develop, but basically a lot of calcium and fibrin is the part of the thing that helps develop blood clots, kind of ties a blood clot down. But other stuff, okay, and fat also, it's just two different types. Most people get this one, some people get this one, okay. It's just two different ways that it happens, okay? And the only way to know is by blood work, and there's actually a special kind of CAT scan that can tell you if you have this one, if you have the calcium problem. It's called a calcium scan, a myocardial calcium scan, heart muscle calcium scan. Again, it's an expensive test. It's not paid for by insurance, but nobody knows what to do with the information. In other words, so it's not because you're drinking too much milk, right? I mean, calcium is in milk and stuff. It's not because of that. It's just because of a genetic problem with you. So they tell you you have it, but they don't know what to tell you at this point to do for it. So it's a kind of a waste of time. So, okay. So now when a blood vessel starts to get damaged because of this fat, one thing we said is it could kind of seal itself off. But another thing is that it could develop a weakened area, right? So inside this artery, there was a puddle of fat inside of it. Okay, we can't see it obviously because it's in the inside, but that changes, kind of starts to change the structure of the artery. And it is possible for it to weaken the artery where a balloon-like piece develops. So an aneurysm is a bulge or a weakening, kind of like when you see a bulge on a tire, right? And obviously the issue is that it could rupture. So if you rupture an artery, the person will probably bleed to death internally. Think about it. We have arteries in our body. You rupture an artery in the brain, the person basically has an intracranial bleed from not having trauma, right? It would be the same as if somebody was struck in the head and a blood vessel ruptured and you saw all those things, the high blood pressure, the slow pulse, the abnormal breathing, all the things you would see, but this is from a medical problem. And there is such a thing. It's called a subarachnoid hemorrhage. Okay. Person usually gets the worst headache of their lives. Okay. And then the blood vessel ruptures and they rapidly become unconscious. In the Jewish community, you hear of, once a year, twice a year, you hear of a woman, okay, otherwise pretty healthy, maybe complaining of headaches for a day or two. And then all of a sudden you hear, that she burst a blood vessel in her head and died. That's what an aneurysm is. Okay, so that's a cerebral aneurysm because it's the brain. You could have it in any blood vessel in your body. The actual blood vessel that's most likely to have it is the aorta because that's the blood vessel with the highest pressure, but it can happen anywhere in the body. So somebody who, has an aneurysm typically feels pain, right? They're going to tell you, I have this pain, but there's no way of knowing, is the pain caused by, no, it can happen in men. Somebody asked why only women, but for some reason, there's a specific type of brain aneurysm called a berry, like a cherry, like a berry aneurysm. And when you hear about it, for some reason, you just hear about it more in females. I don't know why. Like every one I've ever had has been in a female. And all the ones I've had have been otherwise young, healthy, females, prime of life, kids are young, type of thing. I mean, there was one recently, it was an older woman in her 50s, but, it can happen. And it's just they didn't do anything wrong. It's not like they had high blood pressure. It's not like anything. It's just that the inside of their artery was weakened. Sometimes it's genetic. Sometimes it's because of this coronary artery, this would be not coronary artery, but artery disease. It's sometimes it can be, an artery and a vein never meet, right? Between an artery and a vein is that capillary network. So that takes the high blood pressure in the arteries, diffuses it through the capillaries, and then sends it into the vein at a much lower pressure. And the reason why you need to send it into the vein at a much lower pressure is because veins are very floppy, weak blood vessels because they're not designed to have high blood pressure blood in them. So there's a condition called an AV, artery vein, AV malformation, which means that instead of having the capillaries between the arteries and the veins, the artery and the vein meet. Now, the blood from the artery is going right into the vein, and that spot where the artery goes into the vein is very prone to getting an aneurysm because picture this being the artery side, this being the vein side, right? So where the blood is now entering into the vein, it's not used to, the vein is not thick enough and it's not used to that high pressure, and it gets a bulge and it could rupture. So the only way to prevent it, believe it or not, well, one is obviously if you had a family history of it, but the only way to know about it would be to have a top to bottom CAT scan. You know, and sometimes it has to be a CAT scan, what they call contrast dye, you know, because you're looking in a blood vessel. So it's a very high radiation procedure. And I don't think they routinely do it. You'd have to have some kind of risk factor. The other risk factor would be like headaches. You know, you're getting bad headaches, which again, a lot of times people just attribute to migraines. But if you go to a, you know, a good place and you've never had a history of migraines and you're presented with a very, very bad headache, you're going to get at least a CT scan of your head. So if it's a cerebral aneurysm, that should be able to pick it up. I mean, the classic story I always talk about this is that there was a call with Nyack Volunteer Ambulance in the Palisades Mall. So the Palisades Mall has a parking lot that's a, you know, tiered parking lot. In other words, it has multiple layers. And they had to enter the tiered parking lot to go to where the patient was. The guy who was driving was not the smartest person and did not realize that a box ambulance will not fit into the tiered parking lot of the Palisades Mall. So he goes flying up the ramp. If you've ever seen, you know, the way it is there, he goes flying up the ramp and the top of the box hits the wall of the next higher section of the tiered parking lot. The female EMT in the passenger seat was not seat belted, and she flew forward and hit her head on the dash of the ambulance. And she, you know, whatever, she took a good shot. She wasn't unconscious. She was a little confused. You know, the box actually, you know, shifted off the frame. It was like a big thing. So anyway, obviously multiple ambulances showed up and they pretty much insisted that this girl go to the hospital. She didn't want to go, but they insisted that she go to the hospital just to get checked out. At the hospital, they, you know, they did the right thing and they did a CAT scan of her. And she actually had a fairly large, you know, berry aneurysm in her head with no symptoms, not from the accident. It was always there. It was growing, you know, and she had no symptoms. So at some point down the road, that would have exploded and she probably would have died. But because they detected it, what they actually do, I mean, it's a little hard to show it to you, but picture that this thing comes up into like a big ball. So what they actually do is two things now. From the outside, they can go into the skull if it's a very superficial artery, and they put what looks like, you ever see binder clips that you clip paper with, you know, or like hair clips that people clip their hairs. So they actually have a medical version of it. So they take the part, the neck that's going up into the aneurysm, they clip it. And now no new blood can go up into it, and it eventually just collapses. And most of the times they actually just leave the clip in place, and they just tell you never to have an MRI because it can dislodge the clip. The other way is they could actually bring it, depending on where, again, the aneurysm is, they could bring a blood vessel, okay. Oh, it's nickel, the metal. But anyway, they could bring a catheter, a tube, up to the artery, and they bring it up into the neck, right up into the part that's feeding up into the aneurysm, and they fill it, they kind of seal it off. And again, it just eventually collapses down and done. If it's a very large area, they could actually float a new tube into the artery so that no pressure is up against it. So there's a lot of different things they could do nowadays to be able to treat it. Okay, so enough on aneurysms. So again, somebody complaining of aneurysms is going to have an unexplainable pain. And we're going to talk a little more when we do abdominal problems about aortic aneurysms in the belly and in the chest. That's the main place we kind of talk about in an EMT class, but you can have an arterial pressure any place in the body. Okay, so now we're going to switch to problems with the heart. So the catch-all term for all heart problems is called acute, means sudden coronary syndrome. So in other words, some kind of problem with the heart. And then we have to get into all the different problems with the heart. So the three main problems we talk about, and remember, there's probably another 20 or 30, but the three main problems we talk about in an EMT class, okay, are angina pectoris. So angina is pain, pectoris, pectoral muscles, right? That's your pectoral muscles here. Can you see me? I'm sorry. Your pectoral muscles are right here, okay? Your chest muscles. So that means pain in the chest, okay? Acute means sudden. Myo is muscle. Cardial is heart. So heart muscle death, acute death of the heart muscle. That's the medical term for a heart attack. So it's really abbreviated AMI. A lot of people you hear just say MI, myocardial infarction, but acute means sudden, and all heart attacks are sudden. They don't take, years to develop. And then the other night when we did respiratory, we talked about congestive heart failure. Okay, that's where we said the pumping action of the heart was not working well. So fluid is backing up into the lungs and they feel like they're drowning. And we said that CPAP, continuous positive airway pressure device, is a good way of treating that because it pressurizes the airways and kind of forces that fluid out and forces the air down into the alveoli so they have good gas exchange. Because remember, the only thing you're supposed to have in the alveoli is air. So when you have the water, and it's not water, it's plasma, right? Because the blood vessels have too much pressure in them and they're leaking the plasma out of the pulmonary capillaries into the alveoli. But still, if you have fluid down there, you're not having good gas exchange.
Real
Okay.
fast question. If someone has CHF, does that mean the valves are not sealed tight?
So it could be. There's many causes from CHF. Very good question. Sometimes it's the left ventricle not pumping effectively. Sometimes it's the mitral valve or the bicuspid valve not closing completely, so that when this is trying to pump into the aorta, if this is not closing properly, some of it backs up into the left atrium, and then it starts to back up into the pulmonary veins, back into the lungs, and it pressurizes the pulmonary capillaries, right? If you keep on working backwards, it's going to make its way back to the pulmonary capillaries that are wrapped around the alveoli. And once the pressure gets too great in the pulmonary capillaries, the plasma is going to get forced out of the capillaries into the alveoli, and the person's going to feel like they're drowning, right? So that's a very good question.
Is it like, the kids have in the bathtub, they have these little duckies that like when you squeeze it, it squeezes the water out and then it sucks it in. Same with the heart. It squeezes in and then it kind of pushes
Yep.
it.
It's called a Bellows effect.
Right.
Is what it is. So a bellows, I mean, the only way I remember it is, and I don't know if any of you have ever seen this, but years ago when they used to have fireplaces, right? When the main source of heat was a fireplace or a stove, that to get a fire going, like when you're making the barbecue, when you blow on it, it tends to, catch on faster. So they used to have this device that they used to press like this, and it was basically a bag, and at the end of it was a tube, and it would force air out. So that's a bellows, that when you squeeze it, it forces something out. When you opened it, it drew air in. So it's kind of the same thing that happens, even like your lungs, right? Your chest. When you tighten your chest, you force air out. When you relax your chest, you force air in, right? So it's kind of the same thing, but they call it a bellows, B-E-L-L-O-W-S, a bellows effect, but exactly what happens. Okay, so an acute myocardial infarction is a heart attack, and then we talked about congestive heart failure. So now we're going to kind of go into it in some detail. Okay, so acute coronary syndrome can also be called cardiac compromise, like every book calls it a little different. And it's basically some kind of issue where the heart is not getting enough oxygen. Remember, all muscles need oxygen and sugar to be able to work. Okay, so there's a lot of different problems. We talk about three main ones, okay, but they're all under the overall heading of acute coronary syndrome. Okay, now, just so we know, okay, people can be having pain in their chest and it's not a heart attack. On an EMT level, we have no way of differentiating, so we always assume the worst, okay? But, sometimes it could be reflux, right? So somebody has some acid coming out of their stomach up into their esophagus and they get pain, right? Because it's burning and it feels like a heart attack. It feels like pressure, okay? Somebody could have an aneurysm of their aorta, thoracic aorta in their chest, and it's pain. So they may think they're having a heart attack. So there's a lot of other things. Now, on the other way, there is one type of heart attack. Okay, now we classify types of heart attacks. Like an EKG is a tool that's used to determine whether or not somebody's having a heart attack. So first thing you need to know is that somebody can have a totally normal EKG and still be having a heart attack. It's not so common, but it can happen. So even though somebody has a totally normal EKG, you could never say the patient's not having a heart attack. And some paramedics sometimes will tell a patient, well, your EKG looks fine. And that's what the patient wants to hear. And they say, okay, fine, I'll stay home. So you cannot tell a patient they could stay home because their EKG looks normal. So we could say to them is right now, I'm not seeing anything, okay, showing anything on the EKG, but it doesn't mean anything, right? You still could be having a heart attack and you need to go for blood work to determine if you're having a heart attack at that point. Okay, so when we do a 12 lead, we're doing 12 different pictures of the heart, okay? And what it's looking at is which wall, right? This is all muscle, which wall is having the heart attack, or is it all the walls, right? That would be a horrible heart attack. So interestingly, the inferior wall, the bottom wall of the heart, okay, sits right above your belly. when somebody's having a heart attack down there, now remember, what part of our body feels pain is nerves, right? Then the sensory nerves feel the pain and send a signal up to your brain saying you have pain somewhere, okay? But the nerves at the bottom of the heart, okay, when they're aggravated, okay, sometimes make people feel like instead of they're having chest pain, that they're having stomach problems. And now the person says, oh, I must just be having indigestion, goes take some antacids, okay, and, you know, say, okay, I'm not having a heart attack, right? Even though the antacids probably are not going to make the pain go away. So it's definitely an issue. The inferior wall MI is the biggest reason people have heart attacks and don't get treatment right away, right? It's actually the largest payer of malpractice because people tell people, oh, you have stomach problems, you probably have some problems with your stomach, you know, it's not a heart attack, and they leave them home, or they don't treat them in the emergency room as aggressively as they need to. And we would all do it. I mean, I just recently, I'm in the midst of having all this cardiac workup. So why am I having all this cardiac workup? I was doing a very difficult hike where I was basically climbing up the side of this cliff, and halfway up, I get chest pain. And I'm like, oh my God, you know, here I am halfway up this cliff, you know, me of all people, and I'm having chest pain. And I'm like, I can't believe this. So I stopped for a second, you know, I was out of breath, obviously, you know, and then I got scared. And it's not good to be scared when you're climbing up cliffs, right? So I'm like, okay, I got to calm down, because even if I'm not having a heart attack, I'm going to fall off the cliff and kill myself. So I, you know, I kind of calmed down, and I was on a place on the hike where I could, you know, kind of stand. I didn't have to hold on. I sat down, I took my pack off, drank some water, and the pain went away. So I said, oh, it really is heart, because now I'm not exerting myself. The pain went away. Sounds like heart problems. So I'm like, great. So I said, well, should I go down? Should I go up? And, you know, up was shorter and up looked easier than trying to figure out how to go back down. So I went back up. I felt it a little bit, but not so bad. And I was in the middle of nowhere. So I said, well, you know, I got to continue. So on and off, I felt it and everything like that. So the next day, I decided to mow the lawn. Don't do anything about it, right? Don't go to the hospital, of course not. I decided to mow the lawn. So in the midst of mowing the lawn, I feel it again. So I'm like, this ain't good. So I finally decide, okay, you know, I call up one of the cardiologists, I describe everything. And he said, okay, you know, come in, we'll, you know, check you out. So that day I couldn't make it. And then I started saying to myself, I wonder if it's really stomach problems. So I remembered both times before I did the exertion, right, the hike and the lawn mowing, I ate a large meal. So I said, you know, maybe this large meal with all this exertion, it's coming back up. You know, of course, I was trying to, you know, it's called denial, right? I'm saying I'm not having a heart problem. So I basically did the same activities without eating, and I never had the symptoms. So me like an idiot, I go back in the woods, you know, an empty stomach, and I climb back up it, no pain, no nothing. Come back down, no pain, no nothing. I mowed a lawn, no pain, no nothing. So I call the cardiologist up and I say, you know, I don't think I need to come in because I think it's stomach. I need to go see a gastroenterologist. He's like, what are you talking about? And I told him, he goes, well, okay, that's great. You did that, but you still need to come in and get checked out. So last Monday, a week ago from today, I had what's called a nuclear stress test, which was a whole day process where they inject you with a nuclear radioactive dye. And then you do all kinds of exercises to see if it's circulating around your heart. And if it's circulating all through your heart, they know none of your blood vessels are narrowed or damaged. So that came back fine. But of course, because I have good insurance, I have another 4 tests that I have to go through over the next 3 weeks to totally convince the cardiologist it's not my heart. So again, I had GI symptoms, right? It could be this inferior wall MI. Thank God so far on my side, it doesn't sound like it. But that's how people, you know, run into problems. And I'll tell you, we're all in denial. You know, we're all in denial. And, you know, so if I don't wake up tomorrow, you know what happened. I was in denial and I made the wrong decision. Okay, so what we say is that we treat all patients having acute coronary syndrome, okay, signs and symptoms of acute coronary syndrome, as if they're having a heart attack, because we have no way in the field of being 100% certain. We could be certain they are having one, but we can't be certain they're not having one. So like once the paramedics come, if they do an EKG and they could see signs of a heart attack, they could be fairly certain a patient is having a problem, but they could never be certain a patient is not having one without blood work. Okay. Okay, so the most common symptom of acute coronary syndrome is chest pain. Now, how they describe the chest pain, okay, depends on each patient, right? How they describe the symptoms depends on each patient, okay? So it could be pressure, like some people talk about like a squeezing, like there's a belt tightening. Some people feel like there's an elephant sitting on their chest. But I'll tell you, the one classic thing that people describe when they have that aneurysm in their chest is they feel a tearing pain, and that's the actual artery starting to rupture. So tearing pain is not typical of a heart attack, but pressure, okay, weight on their chest, squeezing, can't catch their breath, okay, is more, more of the description of somebody having a heart attack. Now, it is possible for somebody to have what's called a silent MI. Silent means they have no signs and symptoms. And that is very common in elderly patients and diabetics for the same reason, okay, but for different causes. In diabetics, because it damages blood vessels, the nerves start to not work properly and they don't feel pain the same way. That's why sometimes you'll see diabetics who bang themselves and have a bad bruise and they don't even know about it, and then it gets infected, and then it doesn't heal because they're not getting any white blood cells to the area because their small blood vessels are damaged from the diabetes. Okay, and then in the elderly patients, it's just because as you get older, your nerve endings start to, break down, and you don't have the same sensation. So the most common complaint of diabetics and the elderly when they're having heart attacks is often that they're just tired and feel fatigue. We call it general. General means just, nothing specific. General malaise, M-A-L-I-S-E. Malaise is that you just feel, no energy, just tired. Okay. And that's the most common cause. The other person who can have heart attacks without the typical pressure in their chest is women. Women more often than men have that inferior wall MI, and women more often have the complaint of stomach issues. Okay, and once a woman starts complaining of stomach issues, right away people say it has to have something to do with them having babies, even if they're through menopause where they can't have babies anymore, and they don't think heart attacks. Like, we don't think of heart attacks in women the same way we think of heart attacks in men, but they can happen, the same way and stuff like that. Okay. Okay. Thank you, Mordecai. So that's one issue. Okay. So we said that again, chest pain. Now the chest pain can do what's called radiate. Radiate, it means it moves. So they have pain here and it radiates to their arm. Okay. They have pain, it radiates to their jaw. Okay. And so on and so on. So, like, interestingly, my pain, I shouldn't even say I had pain, but I had a heaviness in my chest that went up to right in here. So I had pain in my chest or heaviness in my chest that radiated into my lower jaw, right? So, and again, what is the culprit? It's the nerves in the area. So it meant that the same nerve that was here traveled here on its way back to the brain. And once it felt the discomfort here, it sent, remember, a nerve is just a signal, a wire. I felt the same thing all the way up, okay? And, in my case, it sounds like it was actually just acid, acid reflux from my stomach. So, that's what radiation is. Now, the most common place when people have chest pain from a heart attack where it radiates is actually to their jaw, right? To their jaw, to their neck and stuff like that. Arm once in a while, but most people I've had who have had pain, radiates to their jaw. Okay. Now, who remembers what dyspnea means? Anybody remember? It's the medical term for what? So DYS means something's not working, right? Like
Not breathing.
No, apnea. Difficulty breathing. Good. So PNEA is breathing. DYS means they're not breathing right or they're having trouble breathing. Apnea with an A in front of it, not DYS, but APNEA is not breathing. And there's actually one you very rarely see, but EUPNE is normal breathing. Okay. Tachypnea, tachy, tachy means fast. Tachypnea is fast breathing. Okay. So a lot of times people are having heart attacks, have trouble breathing. It could be from the sensation of pressure, right? That's what happened with me. Like I had this pressure and I felt like I was having a little trouble breathing. It could also be that if your heart attack is actually starting to damage your muscle and then you're not pumping properly, fluid is going to back up into your alveoli and you're going to have that congestive heart failure issue. Okay. So, again, where do you see that kind of thing where maybe they're only complaining of shortness of breath is that elderly and diabetic patient, right? Same thing, weakness, malaise, tiredness, very common in older patients. Geriatrics is just older patients and diabetic patients. Okay. Now, what else do people feel? Okay, definitely get anxious, right? Like I did, you get nervous, right? Okay, feeling of impending doom. So what that means is that somebody will say to you, okay, I feel like I'm going to die. Now, I'll tell you in the beginning, when you hear this from people, sometimes it's going to be just people are what they call hypochondriacs. In other words, they think everything's a real emergency. But I have had, over my 30-something years, I have had people who've looked me in the eye. Typically, they're having a heart attack and they say, Frank, I don't think I could stay awake anymore. I just feel like I'm drifting, I'm going somewhere. And I say to them, I say the same thing all the time. I said, do not close your eyes. Keep on looking at me and talk to me, because I found that when they nod off, they don't wake back up, right? When they close their eyes, they usually do die. And we'll talk about what do we do in those symptoms. Like, what if somebody just codes right in front of you? Okay, so if somebody just codes right in front of you, all of a sudden they're talking to you for 1 minute, the next minute they're dead. Usually when they go into VFib in front of you, ventricular fibrillation in front of you, they have a brief seizure-like activity where they shake. That's because their brain is not getting blood as they're going into VFib. Sometimes you'll see their eyes roll back and they'll, become unresponsive. Punching them hard in the chest is a 1 in a million chance of actually converting them back into a normal heart rhythm, but we do it. It's called a precordial thump, okay? So you just basically haul off, punch them, not with your knuckles because it hurts, but like this, right dead center over their heart. And that punch actually defibrillates their heart with a tiny little shock. And sometimes if you catch it just as they're going into VFib, you'll actually stop them from going or convert them out of the VFib just like a defibrillator will. But the only time you could do it is if you witness it happen. In other words, if you walk in the room and somebody's dead and you punch them in the chest, people are just going to think you're crazy. I'm talking about that the person in front of you codes in front of you, and then a precordial thump may work. Okay. Now, what else do you feel? What else symptoms can people have? So anxiety, feeling of impending doom, nausea means their stomach doesn't feel well, pain or discomfort in the upper abdomen. They call it epi, means above, epigastric, above the stomach pain is very common to people having the inferior wall MI. Okay. Breaking out in that cold sweat, diaphoresis, because they're scared. Okay. They can get tachycardic because they're scared. Or if the heart is starting to get damaged, the cardiac conduction system, the heart is getting damaged, they can have bradycardia. Remember, by definition on the test, a tachycardia is a heart rate faster than 100. Bradycardia is a heart rate slower than 60. Okay. Or especially if their left ventricle is getting damaged, okay, their blood pressure can start dropping. Okay. Normally, when somebody's having a heart attack because they're scared, they get tachycardic and they actually get a little bit of high blood pressure because their heart's beating faster because they're scared, right? So is this tingling in the chest and arms a symptom of a heart attack or acid issues? Most of the times tingling in the arms, the chest and arms is actually nervousness, anxiety, like people are scared. It can be a psychiatric type of thing. And they usually will see them breathing fast when they do that. It's called hyperventilation. So it's usually, more of a psychological thing. But again, there's no 100% way in the field, especially on an EMT level, to know, what is going on with a patient. Because you don't have the same tools that's available, in the hospital. So it's a little challenging, so we always say on a BLS level that you want to treat patients who are having chest discomfort as they're having a heart attack until proven otherwise. Okay. So if someone passes out in front of you, why would I not? You can use an AED, but how quicker? Somebody said, instead of doing a precordial thump, why don't you just get the AED? So if I asked you to put an AED on somebody and shock them, okay, right now, or I asked you to haul off and punch somebody in the chest, what could you do quicker? Right? Do you go into the call, every call with an AED?
What's gonna be more beneficial?
So what would be more beneficial? I would take that second and precordial thump them. And if it didn't work, I would go get the AED. I mean, let's put it this way. You go into someone's house, comes in as a party having a heart attack, a party having chest pain. You might think right now that you're going to say, oh, I bring the AED in. I would tell you that 99.9% of the time, people carry oxygen in. They may carry their first in bag that has their blood pressure cuff and stethoscope. Nobody carries an AED in. The only time they carry an AED in is if it sounds like it's a cardiac arrest. So, and again, if you're just responding to your personal vehicle, unless you got money, you're probably not buying an AED, right? So, and every little volunteer ambulance person doesn't have their own AED. So you do have your hands. So it would be much quicker to be able to precordial thump them. Again, it's let's put it this way. In my life of being a paramedic, I've precordial thumped probably, I don't know, 3-4 people Maybe. So, it depends. And that's me working full time. You may be working one shift a week. You may never have the opportunity to have somebody code in front of you. Good thing, right? But I mean, it may never happen. But if somebody actually codes in front of you, I mean, you're talking to them, they're telling you they're having chest pain, that they don't feel well, they feel like they're going to pass out, and then all of a sudden, boom, they lose their pulse and they become unresponsive, especially if they have that seizure-like activity. Nothing wrong with doing that. Okay, so now assessment-wise, we have somebody complaining of chest discomfort. So again, we're going to do our typical assessment that we do. Okay? Look for any life-threatening problems. Their life-threatening problem is more their heart attack. Okay, so we're going to concentrate on that. Do they have a history of this? Did it ever happen before? Okay, physical exam on somebody having a heart attack, not much. Maybe listen to their lungs, get a set of vital signs. The skin is probably going to be cool and diaphoretic and sweaty, like a cold sweat, but there's not, we're not touching every part of their body if they're having a heart attack. So, do you have history of heart problems? Now, remember, if they say to you, no, I don't have a history of heart problems, do you have a family history of heart problems would also be a very important thing to ask, right? Do you have a history of heart problems? Yes. Does your family have a history of heart problems? Yes. Do you have a history of heart problems? No. Does your family have a history of heart problems? Yes. Right. So just once their family has a history, there's always a possibility that genetically it was passed down. Okay. We talked about OPQRST helping us to remember what to ask. So onset, what were you doing when the pain came on? Provocation, does anything make it better or worse? Quality, can you describe the pain to me? Yes, it feels like there's pressure on my chest. Does the pain go any place from your chest to any other part of your body? In other words, does it radiate? Yes, it's going to my jaw. Okay. Severity, on a scale of 1 to 10, how bad would it be? I usually ask them on a scale of 1 to 10, how bad was it when it started? How bad is it now? Okay. And then if I do something for them, give them oxygen, give them nitroglycerin, whatever it's going to be, does that change the pain at all? Is it still a 9 or did it go down to a 8 or 7? Try not to give them answers. So, instead of saying, does it go down to a 7, say to them, okay, we just put you on some oxygen. Okay. Did it change? I mean, it's not going to change the pain in 30 seconds, but after a couple of minutes, has that reduced your pain at all? Has that changed the number? Before you told me it was a 9, has that changed at all? And time is how long has it been going on? But again, you kind of know that from, onset. Okay.
Severity, if a patient is diabetic, then if he says 2, it's very severe, no?
Right. So, but again, if a patient's a diabetic, they may say to you, I'm not having pain. I just feel tired. I just don't feel well. So my rule with diabetics is if they call the ambulance, I take them to the hospital. That's my rule with diabetics. There's no way of knowing what's going on with a diabetic. And even the little old people, like you'll go on calls with little old people and it'll be their daughter. So, the person's 90 years old, the daughter is 50 years old. And the daughter's going to call you up and say, my mother just doesn't seem right. Okay. Or my father just doesn't seem right. He's more tired. He's a little confused, and I don't know, do you really think he needs to go to hospital? The answer should be absolutely yes. You have no way of knowing what's going on. And most of the times, especially if it's a woman, it's that they're developing a urinary tract infection. Okay. And it's just throwing them off a little bit. And they may not be sick enough at this point where you feel a fever or somebody notices their urine smells or anything like that. But there's just no way of knowing until they get to the hospital and have blood work done. Okay, what's going on? Okay, so again, we ask if there's any past medical history, okay, and get your baseline set of vitals. Remember on the test, they're going to ask you what is the purpose of the baseline set of vitals, and that's your first set that you use to compare other sets to see if there's a difference when you take your second and third and fourth. Did it get better or did it get worse? Okay, so the first condition we'll talk about is the acute myocardial infarction. And that is that a portion of the heart muscle dies because the coronary artery servicing that area is blocked, right? So that's what a heart attack basically is. The usual cause is that they've had coronary artery disease where it's blocked. So if we go back to, I don't know, here. So we have a coronary artery here. They're all over, but let's say we have a coronary artery here. Okay, it originates on your left ventricle, and this one is called your left descending coronary artery. It's the most important one because it takes care of your left ventricle, right? Your left ventricle is the most important part of the heart. The nickname for your left descending coronary artery is your widowmaker, because when you have a heart attack in this one, it's usually not good, right? Because this is what gives blood to the most important part of the heart. Now, you see how as the artery comes, it gets smaller and smaller and branches out, kind of like the roots of a tree. But it starts with a big artery and goes into smaller and smaller arteries, right? So if you have a heart attack, I don't know if you could make it out, but say this little branch over here, if this is blocked over here It's not as significant. I mean, it's still bad because it's your left ventricle, but it's not as significant as if you block this artery over here, right? So the site of where the artery is blocked really depends if someone lives or dies. Because if you block it here, no blood is getting to this whole left ventricle. But if you block it over here, there's a smaller section that's not getting blood. So it really depends on, is it a very proximal blockage closer to where it starts, or is it a very distal blockage further away from where it starts? Okay, the other thing that pertains to it is your age when you have your heart attack. So we would think that younger people would do better in heart attacks than older people do, and it's actually the opposite. And there's a simple reason why. And I keep on telling you that your body always tries to, no matter what you do, keep you alive, right? It always tries to make your mistakes better. So let's say you're 70 years old, and since you're 50, there's been decreased blood flow through these arteries because you ate a lot of fatty foods, okay? So body doesn't say, you know, okay, Frank, you liked all that food, you know, you're gonna die of a heart attack soon. What it says is, okay, you got a lot of clogged blood vessels, let me grow some other ones for you. And that term is called collateral circulation. So when you put money down on a loan, a deposit, that's called collateral. In other words, it's something you're putting down to, you know, pay towards your loan. So collateral circulation in this situation is that you grow additional blood vessels in the area where the body sensed there wasn't enough blood. The problem is that collateral circulation only develops in the 50s and 60s and 70s and 80s. It doesn't develop in the 20s and 30s and 40s. So if you are a person who genetically is predisposed to having a heart attack because your blood is thick, your blood vessels are crappy, whatever, you know, you're just unlucky, your genes aren't good, and you have a heart attack, you don't have any collateral circulation. So when you block this blood vessel, it didn't grow any other blood vessels in the area. So you have a bigger heart attack. Where an older person sometimes will block a blood vessel, and it's always an old blood vessel, and they have newer ones that grew in the area. So they don't have the same issues. Now, it's not to say that older people don't have heart attacks and do bad. They may not have. It's not a guarantee that every one of us develops collateral circulation, but that's one of the things that tends to happen. I think everybody probably knows an older person who, you know, they found out that they had possibly had a heart attack because they had an EKG done and a doctor saw something, but it's old, so don't worry about it. So what they're basically saying to you is that they may have had a very small heart attack, had no symptoms because of that collateral circulation. Okay. We'll give it another couple of minutes and we'll take a break, okay, because we really didn't get into the meat of it yet. Okay, so we talked about that the pain can be many different ways. Okay, we talked about this. Somehow I went backwards. Okay. Now, there's different types of damage, okay? This one is on the surface of the heart, and this is not going to be on the test, but just so you understand, this is on the surface. This one is going through the entire wall of the heart. So if you looked at the surface over here, okay, it's showing, but it's actually traveling completely through the heart muscle. So having a little area on the surface of your heart damaged is not as serious as having what they call, this is called a transmural, means it transmitted through the whole heart. Because I think I mentioned to you what happens, this turns into scar tissue, right? So in other words, becomes a scar. Say this person survives the heart attack. In about 2 weeks, this turns into scar muscle. Scar muscle doesn't move. So what's going to happen is they're still alive. This heart is contracting, but this section is not contracting anymore, right? And what typically could happen to this patient is now they decide to, I don't know, run for the bus or do something that's really exerting their heart. So their heart's squeezing at 10 times more force than usual, but this is not moving. Everything else is moving. And they can have what's called a ventricular rupture or a rupture through, and all of a sudden this piece just pops open. And obviously the person instantaneously dies. Okay. So that's the side effect of a serious heart attack, a big damaging heart attack. It's called a transmural heart attack. Now, this is the outer wall, right? What about, this is called the septal wall. This is the wall that divides the left and right side of the heart, okay? So you have, you have a wall that actually divides one side of the heart from the other. So you can have that same transmural MI through here. And what happens is when they rupture, blood starts mixing back and forth. So they don't die instantaneously because it's contained inside the heart, but now they're just not pumping blood around the right way. And they usually become unconscious very quickly. They still die, but they don't die instantaneously. So there's no way of knowing this. It's something that you hear on autopsy. that they determine on when the patient had an autopsy. So in the Jewish world, they probably never know. Okay. But it's a side effect of somebody having a severe heart attack. Okay. That may or may not cause a problem down the road. Okay. So now what do we do for people having heart attacks? So the first thing is they're scared. Okay. And when you're scared, what chemical do you secrete into your bloodstream? What's your emergency hormone of your sympathetic nervous system, your fight or flight syndrome? It's called adrenaline, right? Epinephrine. So if I squeezed your kidneys right now and made adrenaline come out, because you have adrenal glands sitting on your kidneys. So I punch you in your kidneys, I make that adrenal gland squirt out a little adrenaline. What's going to happen to your heart rate? Right? It's going to shoot up. What's going to happen to your blood pressure? It's going to go up. You're going to breathe faster. Now, if I'm having a heart attack, do I want to make my heart work harder and faster? No. Okay. So whatever we could do to make them comfortable and calm them down. Okay. That includes not looking panic stricken yourself. You're going to go on calls where people look like they're about to die. And if you say, this doesn't look good, and you start getting sweaty and nervous and screaming and yelling, to orders to people, the patient's going to say, if this guy's panicking, maybe I should be panicking. Okay. And actually in the treatment of heart attack patients, a lot of times we give them medications to relieve pain, like morphine and fentanyl and different drugs to relieve their pain or take the edge off their pain, so they don't have all that release of epinephrine, because it's just going to make their heart attack worse. The problem is that on a BLS level, obviously you cannot administer those medications. So whatever you could do to make the patient comfortable. On the test, a lot of times there's going to be questions of, in what position should you transport the patient? If they're unconscious, it's always going to be on their side. Okay. If they're I should say this, if they're a medical patient and they're unconscious, it's always going to be on their side. If they're a trauma patient or unconscious, it's going to be flat on their back. If it's a problem with inside the head, right, a stroke, a bleed, then we want them sitting up on the stretcher on a slight incline, right? They call that like a semi-Fowler's position. So there's less pressure going to their brain. But everything else is position of comfort. I think we had a question about a fracture, right? How should we transport the patient with a fracture? So again, position of comfort, right? So position of comfort 9 times out of 10 is the position we find a patient in, because nobody sits in a position they're not comfortable in most of the times, right? Then we're going to put them on some oxygen. So I wrote here O2 controversy. The reason why is that the protocol used to state high concentration oxygen for everyone, no matter what. We know with the COPD that we can make them a little worse with oxygen. So now they say gear it towards a normal pulse ox. Now, somebody please tell me, what is a normal pulse ox? What's the number that we'd like to see somebody at least? 94%, right? So if they're at 94%, okay, I would just put them on a nasal cannula at 1 liter or 2 and leave it alone. If they're below 94%, I would probably put them on a nasal cannula at 4 to 6 liters and see if that gets it above 94%. If that doesn't, then I'd switch them over to a non-rebreather, and your goal would be to get them above 94%. Now, people are going to say, what's the problem with oxygen? So the issue is in heart attacks, they found that if people had a normal pulse ox, which again is 94% or higher, and you put them on oxygen and drove it up towards 100, they actually had a worse heart attack, because the blood vessels then tended to constrict if they were exposed to super, super high oxygen. Now, what else can we do for patients? The most important drug for somebody having a heart attack is aspirin, okay? We give them chewable baby aspirin. And again, we're going to review this on Wednesday night, but we have them chew and swallow baby aspirin, okay? And it has to be not the coated ones. We want it to go away right away. That's why they chew it and swallow it. What aspirin does is aspirin stops platelets from clogging up the artery. And since most heart attacks are caused by platelets coming and clogging up the artery because of the thrombus, the fat, we give them aspirin. Now, we're not going to reverse what happened before we get there, right? So obviously something happened before we got there because they have chest pain. So we're not going to reverse that, but we're going to prevent any more narrowing, okay? If the patient had a history of angina, they probably have prescription for nitroglycerin. And in that case, nitroglycerin relaxes blood vessels. We don't carry as EMTs nitroglycerin, but if the patient had the nitroglycerin because they have this angina pectoris that we'll talk about in a second, we can assist them in taking their nitroglycerin within some parameters. And there's some things we have to talk about. The blood pressure has to be good and some other things. Okay, and then we have to transport them to a hospital that's capable of doing what they call emergency angioplasty. In other words, doing the procedure to open up that clogged blood vessel. So right now in Rockland, it's only Good Sam. Valley does it, Englewood does it, Westchester does it, White Plains does it. but, and obviously in the city, Mount Sinai, Columbia, they all do it. But right now in Rockland, it's only Good Sam. In Orange County, it's St. Luke's, Orange Regional Medical Center, and I think that's it. So, you have to take them there. In Rockland County, sometime January, February, NIAC will also start doing it. Okay. So it'll be easier. We don't have to take every patient to Good Sam, even if they're over on the east side of the county. Okay. And the reason why, obviously, is even if it turns out they're not having a heart attack, okay, they're still going to get better care at a cardiac center than in a non-cardiac center. Okay. But if they are having a heart attack, then they could have the procedure done. So like if we were to take somebody with chest pain to NIAC, and it turns out they're actually having a heart attack and a blocked vent vessel, they would have to call another ambulance to transport them to Good Sam. Okay, so again, put them on oxygen, make them comfortable, okay, and strive to get their pulse ox to at least 94%. If it's at 94% or higher when you get there, okay, a liter of oxygen, just more or less for psychological first aid, a liter or two of nasal oxygen is fine. Even technically not putting them on oxygen would be okay if they're at, say, 98% or something like that, but we usually still put them on a liter or two of oxygen. Okay, now aspirin. Okay, so the signs and symptoms, right? So signs and symptoms consistent with a heart attack. So they're having chest pain, cool, pale diaphoretic, pain radiating somewhere. Okay, we have to make sure the patient is not allergic to aspirin. Okay, and that there's no history of recent GI bleeding. Recent meaning, today. So I've not yet had a heart attack patient who's been bleeding in their stomach at the same time. I'm sure it's possible. If they tell you that they've had problems with GI bleeding, call medical control and ask them if they want you to give the aspirin. The big one to ask is, are you allergic to aspirin? Okay. Okay, so they have to be able to swallow safely, right, and not choke on the aspirin. And we basically give them 324 milligrams. That's 4 81 milligram chewable aspirin. ASA is aspirin. And you see here how it says non-enterically coated. So you parents may be taking aspirin every day, 181 milligram aspirin once a day because a doctor told them to. And you'll notice there's a hard yellow or green coating over it. That's because, I'll give you guys a break in a second. That's because aspirin taken every day can bother the stomach, okay? So that's why people are taking it every day have to take the one that has the coating on it. Here, we're giving them a one-shot deal. Yes, we're giving them 4 of it, but we're giving them a one-shot deal, okay? And we want it to go to work right away. So we don't want one that has a coating that has to be broken down by the stomach. So we tell them to chew it and swallow it. Now, if the only aspirin you have available, let's say you're at somebody's house or something like that, has the hard coating, you still give it to them, but you make sure that they really crunch it up, chew it, and swallow it well. Now, remember, people are not used to chewing pills put in their mouth. So you have to tell the patient before you hand it to them, I don't want you to swallow this right away. I want you to chew it up and then swallow it. It may not taste good, but you need to chew it up and swallow it. That's the right way to take it. Do not just swallow it, because if they swallow it and it has the hard coating, it's going to take hours to go to work. In fact, if they do that, we just actually let them do it again. We give them another 4 and tell them, now do it the right way. Okay. Or if they told you they took it before you got there, but they didn't chew it up, you would give them another 4 and tell them to chew it the right way now. Now, just so you're not concerned, because I know some people are saying, oh my God, we're giving them twice the dose. When we used to use aspirin for headaches, for fever, and everything like that before there was Tylenol. So I don't know how old everybody is, but some of you may remember taking aspirin, okay? We used to take 650 milligrams for a headache. So you're giving them half the dose for a heart attack that you would have gave somebody for a headache. So you don't have to fear giving them the 324, and you don't have to fear possibly giving them a second dose if you have to. The reason why 324 was picked is that it is effective in stopping the clotting process, and it doesn't have any real side effects. When you start going to the higher numbers, it's still effective in breaking down the clotting effect, but you start running into the possibility of more problems, okay? But again, it's very remote. Like I said, people were taking 650 milligrams of aspirin 2 times a day for headaches, fever, toothaches, and everything like that. It's carried many different ways, but it has to say chewable. Usually it says children, okay? Sometimes it'll say non-coated or non-enterically coated. We don't typically in EMS carry big bottles of aspirin. We usually carry them individually packaged. So you'd actually be breaking open 4 little individual packages. The reason why is that technically you're not supposed to give patients from a bottle that's been opened, right? So here you probably have what, 100 or 50 or 36 tablets. So you're going to give a patient 4, technically you should be throwing away the rest of it. So you'd be wasting 32 tablets. Once it's open, you're not supposed to use it again for another patient. I'm sure people do, but we on the paramedic units carry, it's individual, like a blister pack, just pop them out and you give the patients the aspirin that way, okay? So let's take a break now and we'll come back and we'll pick up with nitroglycerin. So it's 9:20, come back about 9:35 and we'll come pick up with nitroglycerin, okay?
Why aspirin out of all medications? There's other blood thinners, no?
So it's not a blood thinner. It's specifically a medication that stops the platelets from doing what they need to, the problem they're making. Whoops, I didn't want to do that. So that's why we're giving, okay. So somebody asked, I asked when you were trained, did you connect yourself to an EKG? I didn't have an EKG available in the woods. So no, I didn't hook myself up to an EKG. How does aspirin alleviate headaches? Great question. I don't know if it's fully known, but the way it was discovered was aspirin is in the bark of a certain tree, the bark, the outside of a tree. And somehow or another, many, many thousands of years ago, somebody discovered chewing on the bark relieved pain. And that's kind of how aspirin came around. I don't know the exact mechanism. It probably just blocks the pain impulse somehow, but and the same thing, like how does it reduce fever, right? So we have to figure that out. And then somebody else wrote, somebody with unhealthy eating habits now at the age of 36. Is there anything for him to do to undo all the damage? So 36 is not the end of the world. So obviously you can definitely, fix things. I don't know if you make things perfect, but you're not going to do any more damage. I think the thing to do would be to find the right doctor that's willing to take the time, and going to him and saying, look, I know I've messed up until now, and, I want an A to Z, workup and find out where my problems are and see what we could do to fix things if I do have any problems. But 36 is not the end of the world, believe me. People have a, they call it an epiphany. They have a realization, the end is near typically when they get to 50, and then they start trying to do things and stuff like that. So 36 is not terrible. You just have to balance everything, because if you try to do too much too soon, you're just going to burn out and then not stick with it. So it'd be better to go slow and steady than it would be to get crazy with it and stuff like that. Okay, so when would we use nitroglycerin? So the first thing I should really put first is that you do not have nitroglycerin on the ambulance. You have aspirin on the ambulance, you have albuterol, you have EpiPens, but you don't have nitroglycerin. So you don't actually carry it, but if a patient has it, you can help them in taking it. So the first thing is that it has to be the patient's. So let's say the husband has it and the wife is having chest pain. You can't give the husband's nitroglycerin to a wife, right? It has to be the patient's nitroglycerin, okay? And then we're going to talk about some of the other things. But, obviously the patient has to be having something that would lead you, some signs and symptoms would be leading towards you thinking of it either angina, which we have not covered yet, or an acute myocardial infarction, right? So that's the first thing. Then they had to have that history of possessing the nitroglycerin. You don't like to give nitroglycerin to somebody for the first time. So it's nice that, for you guys, that you would only be giving it to someone who's taken it before, because what nitroglycerin does is it dilates blood vessels. Okay, and the reason we give it in chest pain is if you dilate the blood vessels in the heart, you get more blood to the heart, so you relieve the pain. The problem is that nitroglycerin doesn't just dilate blood vessels in the heart. It's what it's called. It's called a generalized, which means works all over, smooth muscle relaxant. So you have smooth muscle in your blood vessels, you have smooth muscle in your lungs, you have smooth muscle in your intestine. So when you give somebody nitroglycerin, you cause smooth muscle to basically dilate everywhere in their body. So like if they were having stomach problems, they'd feel better. If they were in breathing problems, they'd feel a little better. Now the side effect is if you give somebody nitroglycerin who never took nitroglycerin, when it dilates their blood vessels, it could be like a form of distributive shock where it dilates their blood vessels and drops their blood pressure. And it's not uncommon for someone who takes nitroglycerin to get a really bad headache because you're dropping their blood pressure. And it happens, but it's not that common where people actually pass out. They syncopize because their pressure drops too quickly. But that's typically people who do not take nitroglycerin on a regular basis. That's why it'd be good in your situation where you're only using it on people who have a prescription for it. So you'd have to assume that they've taken it, before. Okay. Okay, so somebody just asked, wait, hold on, I did something wrong here. No, I scroll backwards in the questions. Okay, so now how is nitroglycerin carried? The cheapest way to carry it is little white tablets. They look huge here, but they're actually tiny. And they're in what they call an opaque bottle. Opaque means that light cannot get through it. Sunlight inactivates or makes the nitroglycerin not work well. Okay, so this is the cheapest way. This is the most expensive way, where it's in a spray. Okay, this is like $250, $300. These sprays. This is pennies. So depending on the person's insurance, they may only get this. If they have Medicaid, they'll probably get this. But if they have regular insurance, they may only get this. So now, how does nitroglycerin work? Nitroglycerin is what we call a sublingual, under the tongue administration. So these tablets are placed under the tongue, okay, or the spray is sprayed under the tongue. And the reason it goes under the tongue is there's lots of blood vessels under the tongue, and they rapidly absorb the nitroglycerin, and it goes to work pretty quickly. So it's a quick, simple way of giving it, much quicker than them swallowing it. Okay, it's a very quick, simple way of doing it. Okay, now, not that you use it as EMTs, okay, but there's also other ways of giving nitroglycerin. There is paste that we put on a patch and put it on the patient. When we, as paramedics, use it, it's in this form, but patients who have chronic chest pain, that they're always feeling chest pain, may actually have a patch that has nitroglycerin on it already. They just peel off and put on their body. This means that their blood vessels are so severely narrowed that they need a little nitroglycerin going into their body all the time. Now, since the nitroglycerin is on the other side of this patch, if you ever have to remove the patch, you may have to make sure you have gloves on, because if we were to get nitroglycerin on our bare hands, we would pass out. So you have to realize it'll quickly dilate your blood vessels and you'll pass out from it. Now, the question somebody should ask me, why would I ever want to take a patch off someone? So if the guy's having chest pain, you don't want to take it off. But let's say the guy fainted. I don't know, he saw blood or he got bad news and he fainted, and you get there and you go to take a blood pressure on him and you're not getting a blood pressure. You're getting 80/60. Okay. Well, the nitroglycerin is only helping to keep his blood pressure low. So in that situation, we peel it off with a 4x4 or some type of gauze pad, wipe it off, and that should help his blood pressure come back to normal, but it's pretty rare. The other thing is that depending on where the patch is, if you had to defibrillate him and it was on his chest where you'd be putting the AED pad, you may have to also remove it. Okay. Most times people put it actually on their outer arm, so it's not usually an issue. Okay. Somebody asked why we do not use aspirin sublingually, because it's not a medication that would dissolve quick enough and be absorbed sublingually that way. So certain medications work sublingually. It just depends on how they're made, and some don't. That's all it really is. So nitroglycerin works well sublingually, aspirin does not. And the other thing is, nobody probably would keep aspirin under their tongue. The time it dissolved under your tongue would be like an hour or two. It would taste terrible, feel terrible. So it's just not a good way of giving it. We actually now have injectable aspirin for certain situations, as paramedics. Okay, so indications for using nitroglycerin. So the indication is a reason why you would do it. Okay, so again, they're having chest pain, some type of signs and symptoms indicating we think it's either an acute myocardial infarction, a heart attack, or angina pectoris, pain in their chest. And I'm going to tell you in a second the difference between a heart attack and angina. Again, on a BLS level, you're never going to be 100% certain which one it is, but either way, nitroglycerin would be indicated. Aspirin, more indicated in a heart attack than angina, but you're not going to hurt somebody who has angina by giving them aspirin. Okay, so the first thing is the protocol states the patient has to have a systolic blood pressure greater than 120 millimeters of mercury, systolic, right? So the reason why, again, is nitroglycerin can lower blood pressure, so you don't want to give it to someone who already has a low blood pressure. Okay, now, medications for erectile dysfunction, medications that men use to help them get an erection, okay, also work by dilating blood vessels, because for a man to get an erection, he has to dilate the blood vessels in his penis. So since Viagra, Cialis, Levitra, all those different medications cause vasodilation, and nitro causes vasodilation, we don't really want to give two of the same medications together because they'll cause more vasodilation and make it more likely for the person to drop their blood pressure. So we typically withhold nitroglycerin from somebody who's having chest pain, okay, if they take an erectile dysfunction medications. Now, the BLS protocol, the EMT protocol states 72 hours. That's a really long time. That's 3 days. Most people would say, 24 hours would be the most, but the way the protocol reads, it's 72 hours. Okay, so just so you know. The other thing too, the blood pressure that you're limited to is 120, but like the paramedics have 100, so they can go lower. In the hospital, they may even give it at 90. So this is just, they want to be a little safer with EMTs because you don't have any way of managing if the patient faints, right? If they drop their blood pressure, you don't have any other, way of treating them. So they're just making it a little safer. Okay. So after you give the first dose of nitroglycerin, if the pain doesn't go away and the blood pressure stays above 120, you can give a second dose, and then you could wait another 5 minutes and give a third dose as long as the blood pressure stays over 120. So you can give a total of 3 doses, okay, to try to relieve the pain. And that's actually what the patient is told to do. The patient is told to take a dose of nitroglycerin if they have chest pain. If it doesn't relieve it, to take a second dose and a third dose. And then if it doesn't relieve it, to call the ambulance because they may be having a heart attack. Now, my experience with nitroglycerin is usually that 1 tablet or 1 spray will relieve the chest pain. Okay. Sometimes people don't keep the medication properly. They expose it to light, they bounce it around, or they're using expired medications, and it may not work. And it's not that they're still having the emergency, it's just that their medication is old. So I'll tell you 2 quick little hints to know that the medication is still what we call potent. Potent means that it's still powerful, it could still work. The first is that if you do the tablets, okay, and to a lesser extent, the spray under the tongue, they should feel a little tingling or burning sensation under their tongue, especially with the tablets, not so much with the spray, maybe, but more with the tablets. And that'll tell you that medication is still active, is still good, okay? Also, once the medication starts working, pretty much everybody who gets nitroglycerin, whether it's tablet or spray, gets a headache. Okay, it's not a terrible headache, but they get a little pounding in their head. So that will also tell you the medication is good. So if you have somebody you gave nitro, again, you're using the patient's nitroglycerin. Okay, so if you gave somebody nitroglycerin, the pain continued, and they said, I didn't feel any tingling and I'm not getting a headache, you would have to assume the nitroglycerin is not good. Okay. Now, it doesn't help you because you don't have any other nitroglycerin to give, but at least you know it's not like something horrible is going on. It's just a matter that the medication is not good. Okay. Somebody wrote that your book says a blood pressure of 90. That actually is the most common number. Like I said, the paramedics use 100, but 90 is pretty low. So I would stay away from, nitroglycerin. Really for you guys, I think 120 is good, is a good number. You won't run into any problems sticking with 120. Okay, so we said again, we can give up to 3 doses, okay, 5 minutes apart, as long as the pain continues. Okay, the patient hasn't any relief from the pain and their systolic blood pressure stays above 120. Okay.
What about the patient said that he took already three doses in the last half hour?
So again, I would say to him, did you feel it tingling under your tongue? First of all, I would say to him, how did you take it? If he swallowed it, forget about it. It doesn't mean anything. It's not going to work. Nitroglycerin doesn't work by being swallowed. It has to dissolve and be absorbed by the blood vessels. So if he said, I swallowed it, I would check his blood pressure. If he's still having pain, his blood pressure is above 120, I would give it to him again, sublingually, the right way. The other thing is if he, took 3, I would say to him, and took it the right way under his tongue, I would say to him, did you feel it burning under your tongue? Do you have a headache? I would look at the expiration date on the bottle. But again, you don't have any other nitro to give. So if he took it and it was expired, it's not working, you're just going to put him on oxygen transport, right? So there's not much you could do, okay, with it. You just have to make sure a couple things with nitroglycerin. You never, ever give it when the patient is standing. Not that you would ever think to give it to a patient standing, but you don't want to because it's more likely for them to faint if they're standing and you drop their blood pressure. I usually wait till I get them in the ambulance and that they're on the stretcher with their legs up, so that if they start feeling dizzy, I can lower the head of the stretcher and make them feel a little better. Okay. I don't typically give it to them before we get them out of the house, because if you make them faint before you get them out of the house, it's just going to be so much harder to move them. So I usually wait till we get them out in the ambulance to give it to them, stuff like that. Okay, so we talked about the heart attack patient, right? So we said that a heart attack patient, the problem is that there's, because of the fat that developed in the artery, the thrombotic fat, right? The platelets go there, okay, clogs up the artery. They're not getting any blood past it. The only way to permanently correct the situation is to do a procedure called angioplasty, where they actually float a wire, a catheter, with a balloon at the end of it to there. They inflate the balloon, press the fat out of the way, and leave a metal coil. Kind of look, you ever see a ballpoint pen where you click on it and it's got that little metal spring in there? They leave that in there to stop the artery from collapsing back down on it. So they basically push the fat out of the way and leave a scaffolding in there to keep the artery open, okay? Angina Pectoris is a slightly different problem in that here there's no blockage. There's a narrowing, but there's no platelets involved. What happened here is this is the guy who has had that fat in his artery, probably has some of that calcium getting in the artery where it's stiffening it, okay? And now he does something to make his heart need more blood. So he's walking up the stairs. He's, I mean, I'll give you a classic example. When I was learning to, yes, that wire in the heart is called a stent, yes. An angiogram is the procedure. So people are asking some questions. So yes, the device that you put in their coronary artery, not you, but the interventional cardiologist puts in their artery is called a stent. And the procedure to get in there is called cardiac catheterization, but the correct term is an angiogram. An angiogram is a picture of the blood vessels in the heart. So what they basically do is they come in through your femoral artery in your leg, in your groin, and they inject a dye, and they could see the dye getting through the heart, kind of like the nuclear stress test I had, but without a radioactive substance. It's a dye, a color. And where the dye doesn't get through tells them what blood vessels are blocked. Okay, so they're looking at a screen, okay, and they're bringing the catheter and they could see where the dye is not getting through in the heart, and that's where they know that there's a problem with blood flow. And then they go there, they balloon it open, and they leave that stent or that coil in there to keep it from collapsing. Okay, so now going back to what angina is. So angina is this gentleman, okay, who does have the coronary artery disease. That could be the problem of a heart attack and could be the problem of angina, right? It's a problem of what we call acute coronary syndrome, all the issues in the heart, okay? But he didn't have that rupture of the fat, so no platelets went to it. No, there's no platelets involved here. He just has arteries that are blocked, and because the calcium got in there, they can't dilate. So he now does something. He runs for the bus, he gets into an argument, he does something, and he really needs more blood getting to his heart. I don't know, he rakes leaves, I don't know, he's doing something, okay? He's putting sook up, whatever. And he's doing something where, his heart's working harder, so it needs more oxygenated blood. Because the arteries are stiff and they can't open up more, and because they're clogged in the inside, he has a mismatch from the amount of oxygen his heart needs to the amount of oxygen his heart is getting. So he also goes into that anaerobic metabolism, and he also gets the chest pain. But this guy says, oh my God, I'm having chest pain. Let me sit down. And now he notices that when he sits down, the pain goes away. Why did it go away? Because he reversed what he did to bring it on, right? So he's putting the sook up, he gets chest pain. He was a Yeki. He puts it up 3 weeks ahead of time. Well, actually, he was a Yeki. I guess he puts it up a week ahead of time. And, he's not rushed. He's not Hasidish where he's doing it, Erev Yontiv. And he has time to do it, so he's not rushed. So he sits down and the pain goes away. So why did the pain go away? Because he reversed what he did to bring it on. So again, there was no emergent issue in his arteries. It's been like that for 30 years. And when he's not doing something crazy, he's fine. It's only when he does something to exert his heart that he gets the pain. So you get the difference in the heart attack. Something happened to cause the covering over that fat to rupture. The body thought there was a wound and it sent platelets. That person can't change that now, okay? So the only thing we could do is interfere with the platelets sticking by giving him aspirin and get him to the hospital and have that kind of plowed open or pushed open and left with a scaffolding, a stent in there to keep it from collapsing. And in angina, if he stops doing what brought the pain on, the pain goes away. Okay. Now they do give them nitroglycerin, because what nitroglycerin will do is will open up their blood vessels, okay, and make them feel better quicker. But nitroglycerin will not open the blood vessels in a heart attack enough to make the, to reverse what's happening, because as long as those platelets are still flowing there, remember you have millions of platelets in your body, as long as those platelets are trying to cover up that perceived wound, that false wound, it's going to keep on closing the artery. So the only way to fix the problem is to kind of push everything up out of the way and then continue giving them their medications to interfere with the platelets for hours. Sometimes actually for weeks, they give them a medication called Plavix. And, they keep them on that for weeks to, stop the, hold on one second. Do you need something? That's the issue with angina pectoris.
Does nitroglycerin help for angina?
Yes, nitroglycerin will open up the coronary arteries so that more blood will get through them and the pain will go away quicker.
Yeah, but isn't the artery didn't become hard? You said that.
Yes, it did. It did get hard. Okay. In fact, old people don't call it angina; they call it hardening of the arteries. But it will help. It absolutely will help, because this is a temporary problem. Once they stop doing what brought the pain on, okay, and once, in other words, like if you were running for the bus and you got chest pain, once you sit down and relax, automatically you're going to start feeling better. So, most people never take their nitroglycerin because the pain starts going away. Typically, the pain will go away within 5 to 10 minutes. Some people take their nitro, some people don't. Usually by the time we get there, the pain has gone away. They'll say to you, I have this problem, when I'm walking up lots of stairs, I get chest pain, and I know about it. And this time, I went too quick and I got some chest pain. My wife got nervous. She called for you guys, but I'm already feeling better. And we usually say to them, can we check you out, and stuff like that. And most of the times they're not going to want to go to the hospital because the pain's gone away. Remember, the pain of a heart attack will never go away until they have angioplasty. Angina, they will become pain-free. Usually, I would say, like I said, 10 to 30 minutes, they will be pain-free. More towards the 10 than the 30. Once they stop, it's called precipitating factors. Precipitate means what caused it. So once they reverse to precipitating factors, once they reverse what brought the pain on, they automatically start feeling better. It's just a question of how quick they feel better. And remember, some people get very nervous. And when you get nervous, you secrete adrenaline. So it's going to be longer for them to, feel better. Now, somebody asked, once the stent is in, how do the platelets know to move on? So the very good question. The stent is coated with what they call a drug-eluting substance. So what it means is it's coated with a medication that doesn't allow the platelets to stick anymore. And that stent has that medication painted onto it, and it lasts anywhere from 3 months to a year. So it's a good question, because that's typically, so real quick, before the angioplasty was the first procedure. That's ballooning open the artery. They didn't used to put a stent in. They didn't have stents. They didn't know about stents. So they used to balloon open the artery, and about 50% of the patients, the artery would collapse within a week and they'd have a new heart attack. Okay. So then they went on to stents, right? They said, okay, let's leave something in the artery and keep it propped open. So they invented stents. Then what happened was the body said the stent doesn't belong here, so let's cover it, right? It's not, it doesn't belong here, let's just cover it up. And they would have a heart attack because they would cover up the stent. So then they now have stents that have a drug-eluting substance on it that stops the platelets from sticking to it, so it can't cover it up. So that's the latest and greatest version of things. I mean, they even have a procedure, they don't do it very often, where they bring a tube that kind of has like a, I don't know how to describe it, but kind of like a grinder, and they go through the fat, and there's suction on this device. So it goes through the fat and starts to chop it up and suck it back out of the body. Okay. They have to put past the artery kind of a filter, so that if any pieces break loose, it catches it. Okay. And then they go through and they try to like rotor-rooter it, like a clogged drain, clean it all out, suck it all out. Then they suck the filter, and then they bring everything out of the body. But it's a much more longer, dangerous procedure. But and they still wind up leaving a stent. So most of the times they just do the angioplasty where they push the fat up out of the way, and they just leave the stent in. Okay. So just a couple terms here, right? So the pain, just like the pain of a heart attack, is insufficient blood flow, but angina, it's temporary, and a heart attack, it's permanent until they have angioplasty. And then the term, again, you're not going to see in the test, but increased myocardial oxygen demand. So all we're saying here is how much oxygen the heart needs at a given time. So for those of us sitting now, our heart needs very little oxygen. Mine needs a little more than yours because I'm talking. Okay, but if we all got up and started running, we would need more oxygen. So we have healthy coronary arteries. So we can meet that demand, right? We can open up our coronary arteries, get more blood to them, and we will not have chest pain. Somebody who has cardiovascular disease, coronary artery disease, their arteries are stiff and clogged. They can't do that, so they get chest pain because they can't get enough blood to their heart, and they have that lactic acid buildup. Okay, did I explain it well enough? Does everybody understand? So angina, temporary. When they relax and change what brought the pain on, the pain starts to go away. Okay.
Is angina dangerous if he feels the chest pain and he keeps on running? Let's say he goes on a treadmill and he feels the pain. Could it get him into?
Yes.
Mm-hmm.
Yep. So yes, if somebody has angina, nobody does it. I mean, you'd have to really, I mean, I consider myself pretty stupid, but if that would be kind of like, I don't know, I was having that chest pain and it was getting worse and worse, and I was just climbing higher and higher. I mean, it's like, yes, I'll tell you a classic thing, shoveling snow. So I know it's not probably a huge thing in the Jewish world, but let's say, I don't know, when I go out and shovel snow, I want to get it done. So in the midst of shoveling the snow, I get chest pain. And I say, oh, you know what? I only got like 20 feet more. Let me continue shoveling the snow. Right. So that's typical. Like that's a man's, thinking, like you got something you got to do. Let's just get it done. And that's where people are running into problems. And remember, cold makes your blood vessels constrict even more. Right. So you're much more likely to have a heart attack shoveling snow probably than anything else because you're cold and it's very hard physical labor. Okay. Now, the last thing is angina is brought on, right, with activity, with stress, with work. A heart attack, believe it or not, 95% of heart attacks you're going to go to, you're going to say to the person, what were you doing when you got the pain? And they're going to say nothing. Sitting here, talking to my wife, watching TV, eating some food. Because it's not exertion that causes a heart attack. It's just not luck. It's that that cap over the fat, that covering over the fat on the inside of the artery broke. Okay. They do now know certain things that make it more likely to break. Stress, okay, high blood pressure, infection. So certain things make it more likely to break, okay? But still, you could have people that really have like totally clogged arteries and they get no symptoms. Nothing happens and they never die of it. They may find it on autopsy when they die of something else, but they never die of it. And you get other people, they're just not lucky and it happens. So that's the problem. But it is the poor diet that makes the condition occur, because if you didn't have a poor diet, you wouldn't have all that fat in the arteries. So that's the that's the situation there. Okay. So somebody asked some questions. Is angina pectoris prone to lead to coronary artery? The opposite. So angina doesn't lead to coronary artery disease. Coronary artery disease leads to angina. Right? So having that poor diet and having the fat in the arteries is what leads to angina, is what leads to a heart attack. The only difference between angina and a heart attack is angina is temporary, okay? And that there is no permanent blockage, right? It's just a temporary mismatch in the amount of oxygen your heart needs to the amount it's getting. And the reason it's not getting it is because the arteries are narrowed because of the fat and they're stiffened because of the calcium. In a heart attack, because of the rupture of the cap over the fat and the platelets are clogging it up, it's a problem that has to be repaired, and it's not a simple repair. I mean, it's an in the hospital, major procedure to repair it. Okay, so any questions on those? Okay, so let's review real quick. Oh, so somebody says, if angina pectoris is frequent, does it need med? Yes. So how do they prevent somebody from having angina, right? So again, the first step would be to give somebody nitroglycerin for if it ever happens. But now if they're having it more frequently. So the first thing is they may give them a nitro patch to give them some nitroglycerin coming all the time. But if it's really bad, they may go and do an angiogram, map all their coronary arteries, and try to find the ones that are the most narrowed and leave the stent in them, open them up and leave the stent in there. So they may just, this is not emergent angioplasty, you know, and they're not having a heart attack. It's elective, you know, they don't have to have it immediately. But if it's really, really bad, they may just go and, you know, I don't know, pick the two worst arteries and kind of stent them open and see if that helps. Okay. Okay, so congestive heart failure, we said there's a problem where blood is not going out the left ventricle into the aorta effectively. Because of that, it starts to back up into the left atrium, back up into the pulmonary vein, back up into the pulmonary capillaries that are wrapped around the alveoli, and it flows back in. Many, many different reasons. It could be problems with the heart valves. It could be that the blood pressure in the aorta is too high because somebody has high blood pressure and the heart can't pump out against it. It can even happen in COPD patients because long-term COPD patients damage their blood vessels, you know, in their lungs because of the high blood pressure, because of the problems breathing. It can happen because of left ventricular muscle damage because they had a heart attack. It could happen because they have an infection in the muscle of their heart. There's so many different reasons. We don't really care. But this is somebody who basically all of a sudden gets acutely short of breath. And when we listen to their lung sounds, we hear rails, we hear that crackling down there. They're very scared, very anxious, very hard to you know, guide in treatment. Everything we do, they kind of make it harder to do and stuff like that. They need oxygen getting into their alveoli. The fluid is interfering with the oxygen getting into their alveoli. And because they're hypoxic, because they don't have enough oxygen going to their brain, they don't follow commands. So they start ripping the non-rebreather off and they start fighting with us. It's a very difficult patient to manage, okay? Thankfully, a couple years back, they added CPAP to what EMTs can do, okay? And again, if you can convince the patient to keep the mask strapped to their face when they go to take a breath, it's much higher pressure coming into them, and it forces that air, that oxygenated air, down into their alveoli, pushes the fluid aside, and they'll start feeling better. The problem with it is you are not going to ever feel super comfortable with using it because you don't practice it enough, okay? And because the patient is crazed from that feeling that they're suffocating, and you now sticking this big mask over their face, they fight you. So, you know, it's just time and experience and feeling comfortable with the device and treating enough patients and feeling confident enough yourself to do it that will give you the ability to be able to convince these patients, because you're basically being like a used car salesman, you know, like, trust me, I know it's good for you, you know, work with me, give me 5 breaths, you know, and so on and so on to kind of convince them to leave it in place. So it is challenging. Okay. Okay. What time is it? Oh, we got a lot to do. Okay. Okay. So now the worst stage of congestive heart failure is when they go into acute pulmonary edema. Okay. And that's the sudden emergent, you know, they're foaming at the mouth, their lungs are so full of fluid and stuff like that. So that's the issue there. Again, CPAP is the way basically to treat those patients. Okay. Now, just a term here, just to introduce, and again, it's not going to be on a test, left ventricular hypertrophy. So hypertrophy means that a muscle is getting thick. The heart is the only muscle that does not work well when it gets thick. Okay, it actually works less efficiently. So if somebody has chronic high blood pressure, okay, where their left ventricle is straining to pump into their aorta every contraction, every time it's going like this, what will happen is the left ventricle will get very thick and will not beat efficiently. Okay, and now blood will start backing up. So that's a cause of congestive heart failure from high blood pressure. Obviously, if the valve between the left atrium and left ventricle fails, blood will go backwards. If they've had a heart attack involving their left ventricle, it won't squeeze with the same force. But again, when it comes down to it, as an EMT level, you don't really need to know the cause of it. You just need to know that these people need oxygen. And the best way to give them the oxygen is the CPAP. And it's just a matter of feeling comfortable and using the CPAP, you know, feeling comfortable in using the CPAP and convincing them how to use it. So what do you see in congestive heart failure? They're tachycardic because they're scared. They're short of breath, dyspnea, right? They're having trouble breathing. They're probably going to be cyanotic around their lips. Okay, their blood pressure, most of the times I've seen it has been elevated. They're going to have that cool, pale sweat again because of the adrenaline that's causing the tachycardia. And when you listen to their lungs, they're going to have rales because they have fluid in their lungs, right? They have pulmonary edema in their lungs. They're very anxious and scared, okay? Very hard to control them. Now, you can have problems where it's the left side of the heart not pumping into the aorta, but you could also have problems where it's the right side not pumping to the lungs. So, and then you could have a combination where it's a right-sided problem of the heart and a left-sided problem, and you could have both. But if it's only right-sided, since the blood is backing up, not into the lungs, but back up into the veins that are bringing blood into the lungs, all the other veins you're going to see are going to start filling up. So you see jugular vein distension, okay? You see the liver and spleen starting to get very swollen, okay? And you see the fluid around their ankles, the skin around their ankles get swollen. That's right-sided heart failure. On the left side, since it backs up into the lungs, they get hypoxic very, very quickly, okay? So on all of those patients, oxygen is the way to go, and CPAP is the best way to give them oxygen. Obviously, they need to be sitting up because if they lie, not that they will ever let you lie them flat, but if they are lying flat, the fluid has more area of their lungs to pool over, and they'll be much more shorter breath than if they're sitting up, because if they're sitting up, the fluid is pooling down towards the bottom.
Why would they have high blood pressure? They should have low blood
They're
pressure.
scared. Whenever
Yeah,
you're
but
scared,
heart is not working good.
I know, but when you're scared, adrenaline is secreted into your bloodstream. If they have pulmonary edema and low blood pressure, if you remember from the shocks, that's called cardiogenic shock. That is one of the rarest shocks, but that's where the left ventricle is shot. It's just not squeezing. It's really like pre-death. These are people who need heart transplants. Remember I mentioned that they have a device called a left ventricular assist device, which is kind of a pump they insert in their abdomen. And there's a hose coming off their left ventricle that takes the blood from their left ventricle, pumps it into their aorta. So it's like a second pump, an artificial pump that goes in their body. So again, it's rare. I mean, cardiogenic shock in the pre-hospital setting in the field is pretty rare. It's usually people who have had a heart attack, a bad heart attack, and they're still in the hospital. Okay, and really the treatment would be to have a heart transplant, but there's not a lot of hearts available, so they put that pump in sometimes as a temporary thing until a heart becomes available, or actually sometimes as a permanent thing. And you know, people are dependent on a machine to keep them alive. Okay, so I need to pick up the pace a little bit because I really want to try to get this done so we can devote pharmacology, you know, alone on Wednesday night. So we got a bunch of slides to go through, but a lot of it's just a review of CPR, so it'll be pretty quick. So we just talked about mechanical problems, right? Pumping problems. Now let's just talk 1 second about electrical problems. So obviously you could have, right, there's different functions of the heart. So the heart knows how to beat or when to beat because of its internal pacemaker system. Remember we said the heart has its own nerve fibers to tell it to beat, the SA node, the AV node, right, and all that stuff. It doesn't need the brain to tell it to beat. So obviously if there's a malfunction of the electrical system, the heart will either go too slow, which is called bradycardia, or too fast, which is called tachycardia. Obviously, if it's beating too slow, it's just not beating enough times a minute to generate an adequate blood pressure. But what's the problem when it starts beating too fast? Now, too fast, we're really talking heart rates approaching 180, 190, 200. This could even get to 300. And we said there the problem is what's called the ventricular filling time, which means that when the heart starts beating real fast, the time between each contraction is so minimal, there's not enough time for the chambers of the heart to fill with blood, so they don't have anything to pump out. Now, there's nothing you could do on a BLS level for somebody who's bradycardic or tachycardic other than put them on oxygen and get them to the hospital, right? I mean, obviously, if you have paramedics, there's different things we could do. There's medications, there's electrical treatment and stuff like that. But, you know, these people either way belong in the hospital, right? It's not something that we're going to 100% fix in the field. Okay, now cardiac arrest. So cardiac arrest is not a heart attack, right? A heart attack can lead to cardiac arrest, but cardiac arrest means we don't know the cause. Could be a million different reasons, but the heart has stopped, okay? It may be that it's just shaking like in ventricular fibrillation, but there's no cardiac output. There's no blood leaving the heart, right? So they always have a question on what they call the chain of survival. The chain of survival is what needs to happen for a patient to stay alive for having a cardiac arrest, okay? So somebody has to know they went into, somebody has to know they went into cardiac arrest, and it's usually a bystander, right? Somebody not EMS, somebody a bystander, and they have to activate the emergency response, which is 911. Hopefully that bystander knows how to do CPR so that they could start keeping the organs perfused. and that somebody should have an AED. That's why there's public access defibrillation. That's why the public with no training is allowed to use defibrillators, okay? Then there has to be response from the ambulance, and it doesn't matter if it's BLS or ALS to start with, because in all honesty, most patients in cardiac arrest are in VFib, and most BLS ambulances, at least in New York State, all BLS ambulances have people trained in CPR and have defibrillators. Okay, but depending how far you are from a hospital, it would be good to have advanced life support, which are the paramedics. But in Rockland County, I don't think it makes a big deal. As long as you don't stay on the scene and you just transport the patient right away. And then there has to be what they call integration. In other words, that in the hospital, there has to be a team to manage this patient, to stabilize them, get them out of cardiac arrest if they're not brought out of cardiac arrest in the field, and then to figure out why they went into cardiac arrest and prevent them from going into cardiac arrest again, right? So it's a whole kind of system that has to be in place, okay? So again, we need somebody to notice it. We need, emergency activation. We need early CPR, and that really needs to be bystanders. They do have CPR instructions by the 911 phone operators, right? So somebody says, somebody collapsed, and they say, do you know CPR? No, I don't. Well, we'll talk you through how to do it. And they will, they have like a flow chart that they have instructions on how to talk them on how to be able to do it. Now, this concept of high performance CPR is that what it means is that at least the EMS knows how to do very effective CPR, that they're pushing hard enough, fast enough, okay? And again, we know that we have to compress an adult to at least 2 inches, to a child to about 2 inches, and to an infant to about 1.5 inches, and that we have to allow the chest to come back to normal so the heart can refill with blood, and that basically it's 50-50, half down, half up, right? So half pushing out, half refilling and stuff like that. We know the correct position is just right above the xiphoid process, or if you're measuring from the nipple line, you want to be a little below, right, on the lower half of the sternum, okay, that we need to compress 100 to 120 times per minute, okay? We don't want to spend an excessive time ventilating, okay, on a patient, because it's not the problem with getting oxygen, it's the problem with circulating the oxygen, and there should be no interruptions in any CPR for more than 10 seconds. A great book thing, but if you're on the 3rd floor, no elevator, and the patient weighs 400 pounds, trust me, you're going to have massive delays trying to get that patient, out. But on the test, 10 seconds, okay? So again, high performance CPR, circulating blood effectively. People do, even EMS people, we do horrible CPR, and that's why we have mechanical machines, to do CPR for us. I hope they showed you the Lucas at some point when you were doing CPR, but the Lucas is a battery operated CPR machine that does perfect CPR and stuff like that. Again, if they're in VFib, the only thing that will take somebody out of VFib is defibrillation. Remember, CPR will not take somebody out of VFib. CPR keeps the organs perfused until they can be defibrillated. So if you ever hear of the story of that somebody was in cardiac arrest and somebody came and did 3 minutes of CPR or 3 compressions of CPR, whatever you want to say, and the patient woke up and thanked them, that patient was never in cardiac arrest. They fainted, and the pain of the compressions just woke the patient up. Okay, so, and that happens. That happens all the time. People show up, they want to help, okay, and they don't check for a pulse, and they start CPR. The patient was never in cardiac arrest. They just fainted, and the pain of somebody pushing on their chest wakes them up, okay? And then again, advanced life support would be either that the paramedics rendezvous or meet with the ambulance, the BLS ambulance, or we get the patient to the hospital and they render advanced life support there, okay? And again, the teams together at the hospital, to basically try to keep that patient going. In other words, like, let's say you have a cardiac arrest save and the patient doesn't wake up, okay? So they're pumping blood. They may even be breathing on their own, but they're not waking up. So then we have a process of cooling their brain, okay, and sedating them for 24 hours to give their body time to recuperate. And then they slowly start warming them and slowly start waking them up, and they tend to wake up without a lot of brain damage. So there's a lot of different things that are done, for patients, okay? So what do we need to do? We want to keep them oxygenated, but we don't want to over-oxygenate them. Remember, we said the same problem with the heart attack. We don't want too much oxygenation. So any place above 94% is great, okay? The 12 lead EKG, again, is not on a BLS level, but, on an ALS level, so we're not doing EKGs. Okay, is there anything we could do to try to reverse the cause? So if it's VFib, we have our AED. If it's hypoxia, we can ventilate them, right? So if there's anything like if it was a drowning, you could assume the reason they're in cardiac arrest is they're hypoxic because there's water in their lungs. So we don't worry so much about getting the water out of their lungs. we worry more about getting air down in their lungs, right? Because if we can get air in their lungs, the water will get just reabsorbed by the body. The appropriate destination is a hospital. If you have a choice between a hospital that's a cardiac center and a hospital that's not a cardiac center, you would always want to go to the hospital that's a cardiac center, even if it adds 15, 20 minutes to the transport, right? Because they have the ability to treat them properly. This hypothermia is, again, the protecting of the brain. We used to do it in the field, but they found that it doesn't matter if it started in the hospital, started in the field or started in the hospital. So to reduce time on the scene, we no longer do it in the field. We just get them to the hospital as quick as we can and stuff like that. But we used to, until about probably 10 years ago, we used to do it in the field. Okay, so as EMPs, we do two very vital parts of this. We get CPR going. And also part of early CPR is training the public, right? Every volunteer ambulance corps should have CPR classes available to the public because you want the public to feel comfortable doing CPR and using an AED so that they will help, people doing anything. And remember, in this situation, compression-only CPR is fine, right? The patient does not have to be ventilated. If somebody just wants to do compressions and not put their mouth on someone, we encourage them to do that because most people, when they go into cardiac arrest, are breathing fine prior to going into cardiac arrest, unless it was a drowning, okay, or unless it was a breathing problem that led to their cardiac arrest. And since the vast majority of adult cardiac arrest is VFib, and it was just an abnormal rhythm that hit them out of left field, they were probably breathing fine until they went into VFib. So early CPR, early defibrillation. The only AEDs that we see in our area are what they call semi-automatic, which means that the EMT has to press the button for the shock to go in. There are fully automatic AEDs that you put the pads on, you turn it on, and it decides if it needs to shock. And when it's going to shock, it gives like a 10-second, screaming warning, and then it shocks. So there's no interaction on the part of the EMT, but EMTs do not use that. That's usually just for the general public. And I have not seen one of those anywhere in years and years and years, because obviously if somebody's touching the patient and not paying attention to the warning, they can get shocked accidentally. So pretty much the only thing you see is semi-automatic AEDs, okay, which means the automatic part is that it analyzes the rhythm without any need for you to get involved, but when it decides to shock, you are the final safety check to make sure nobody's touching the patient before the shock is given, and you press the button to deliver the shock. Don't worry about that, semi-automatic versus fully automatic, and don't worry about this monophasic or biphasic, but basically it's the way the electricity is delivered to the patient, the form of the electricity delivered to the heart. And we used to use monophasic machines. Now we use biphasic machines. And what it is that the shock goes in two directions, to the patient and back. So it goes through the heart both ways, into the heart and out of the heart. And the advantage is it works better and you need less electricity to stop the heart from shaking. So you're doing less damage to the hearts, but you don't need to know that on the test or anything like that. It's just that any AED that's purchased in the last 10, 12 years is a biphasic machine. Okay. So how does an AED work? There is a computer program that analyzes the patient's EKG, and it's looking to see if the patient's in ventricular fibrillation or in ventricular tachycardia at a rate of over 150 beats per minute. If it's in either one of those, it will shock the patient. But you need to check that the patient doesn't have a pulse before you put it on them. And the reason why is that obviously if the patient's in VFib, they will not have a pulse. But somebody could be in VTAC at 150 beats per minute and have a pulse and be talking. If you, for some reason, were to put the AED on them, it would charge up. Obviously, it wouldn't shock the patient until you press the button. But that's why we always say that, first you have to make sure the patient is pulseless before you put an AED on them, okay? And again, the only two rhythms, okay, that it will shock is VFib and ventricular tachycardia at a rate of 150. The reason they would say to shock VTAC at 150, okay, without a pulse is that it's a dead patient. It's a dead patient in a fast rhythm, and VFib is a dead patient in an out of control rhythm. So either way, you want to stop the rhythm, and the way you stop the rhythm is by putting electricity through the heart and resetting the heart. So, and you're not going to know the difference. The machine's not going to say to you, is this VTAC at 150? Do you want a shock? It's not going to say. All it's going to do is analyze the rhythm, and it's going to assume, since you told it to analyze the rhythm, you put the pads on, that the patient's in cardiac arrest has no pulse. And then it's going to say, okay, it meets the criteria of VFib or it meets the criteria of VTAC. So I'm going to charge up, and when they press the button, I'm going to shock. Okay. Again, we want minimal interruptions in CPR. Okay, so for less than 10 seconds. Okay, but you do need to stop CPR, okay, to analyze the rhythm. So once you put the pads on the patient, the AED will say to you, stand clear, analyzing the rhythm. Then it'll say stand clear, analyzing the rhythm, because it checks twice, and then it'll decide whether or not it needs to shock or not. Okay. So again, when you pull up, if somebody else is doing CPR, you have them stop CPR. Okay, check, make sure there's no pulse, no breathing, that the patient's truly in cardiac arrest. And if they are in cardiac arrest, you're going to, get ready to use your AED. If it's a male patient and they're very, very, very hairy, okay, and I'm talking extremely hairy, you may need to shave where the pads go on. Okay, there is what they call prep razor, which is a razor used to prep people for surgery. It's a disposable one-time use razor that you cannot cut the patient with. It doesn't shave bare skin. It shaves a tiny little bit above the skin, so there's no way of actually cutting the patient, but it removes enough hair that the AED pads will actually adhere. And most AEDs have the bag that the AED is in, and they have a little other bag hanging off it, or they have a pocket on the AED bag, and that's where all that extra stuff is. There's usually gloves and the prep razor and a pocket face mask and another set of pads in some of them and stuff like that. Remember I showed you with the nitroglycerin patch on the patient. So if there's a patch in the way of where the AED pads go, then you would want to remove it, okay? And if you see a bulge on the patient's chest, that may be an implantable implantable defibrillator or an implantable pacemaker. Not that you cannot shock them, you just want to adjust the pad placement so that the center of the AED pad is not over that. It's really not an issue because 90% of the time they implant the implantable pacemaker or implantable defibrillator on the left side of the chest, and one pad goes here and one pad goes down here, so it's nowhere near that, so you don't have to really worry about it. If it's a patient under, typically they say, I think on the AED pads they say 55 pounds. If it's under 55, and it says right on the pads, if it's under 55 pounds, we typically use the pediatric pads. And if it's over 55 pounds, we use the adult pads. When you plug in the pediatric pads, it actually cuts the amount of electricity coming out of the AED by half because it's a smaller patient, okay? But if there's ever a test question that says that you have a child in cardiac arrest and you have an AED with only adult pads, are you allowed to use them? The answer is yes. And that is because, again, if somebody's in VFib, the only way to stop the VFib is to defibrillate them. Okay, so you just have to be careful. Now, this thing about overlapping down there and stuff, that's not an issue because when we're defibrillating with pediatric pads, we put one here on kids and one directly behind them in between their shoulder blades. When we're doing adult, we do anterior lateral, right? One here and one here. Okay, but with pediatric patients, one dead center in the middle of their chest and one directly behind them. And there's pictures right on the pads telling you where they're going. So I guess what they're saying here is that since you would be using you don't have pediatric pads and you're doing the adult pads, the picture is going to show you not front and back, anterior posterior, but it's going to show you anterior lateral because it's really adult pads. But if you're using it on kids, I would do, front and back the way it shows you on the peds pads. Okay,
the one you put front and back is not only for infants?
It's for anybody over under 55 pounds. Whatever it says is the cutoff on the pad. It'll tell you, it'll say, on the adult pad, it'll say for greater than 55 pounds and or whatever the weight is. I mean, everyone may be a little different. And for pediatric patients, it'll tell you for less than. Okay, so it'll say right on there and it'll also show you pictures of where it goes on the patient's chest. This is showing you the bump that would appear on a patient's chest if they had an implantable defibrillator or implantable pacemaker, or actually most of them are both now. They're a combination of a pacemaker, which can send signals to the heart to get it to start working or to get it to beat in a normal rhythm, or a defibrillator to shock the patient. They typically put this in somebody who survived a VFib cardiac arrest, right, who was saved, and they put it in so that if they ever go into VFib again, the machine shocks them immediately. They don't have to wait for the ambulance to arrive. Looking at this guy, right, this you see right off the bat, and you see he's got a pretty big scar, right, running down his midline, so he probably had open heart surgery. This is not in the way. So if this is an adult, you're going to have one pad over here and one pad over here, so you don't have to worry about it. Okay, so 99% of the time, that's where it is.
If his own AED doesn't shock him, why is my AED going to shock him?
So you never know, right? I mean, first of all, these are low energy machines, right? Because there's a wire going from this machine right to the heart, so it doesn't need a lot of electricity. You don't know if the wire shifted. You don't know. I mean, what do you say to him? I mean, guy's in VFib and he had a defibrillator, so you're going to say we're not going to shock you because you have a defibrillator. So if he's in cardiac arrest, even though he has this, first of all, it could just be a pacemaker. You don't know, right? You have no way of knowing looking from on the outside of his skin. And the second thing is if it didn't work, why not just give it a shot? You never know. I mean, it could be your machine works better than his machine does. So, you know, if they're in VFib and the machine says shock, you go ahead and shock. Okay.
That wouldn't interfere?
Nope.
If it's
Will not interfere. Will not interfere. You don't have to worry about it. Okay. So again, while one person's doing CPR, the other one is getting the AED. Hopefully you have 3 people. So one person could be doing chest compressions. Another person could be ventilating. You're getting the AED ready. The only time you have to stop CPR is when you're analyzing. If for some reason you can't get the pads on in the right position with somebody doing chest compressions, then you would have them stop. But you're always going to start CPR first, unless the patient coded in front of you and you had the AD available. If the patient codes in front of you, you have the AD available and you can quickly get it on them, then you go ahead and put the AD right on. But if you walk into the room and the patient's lying there, it's always going to be 2 minutes of CPR before you give that first shock so that you could reperfuse the heart, circulate blood and get blood to the heart before you shock it. Okay, the adult pads, so 55 pounds or 8 years of age, anterior lateral, pediatric pads under 55 pounds, anterior, posterior. This is the best way to defibrillate everybody, but on adult patients, if you're by yourself, it would be impossible to roll them and get them in the right position quickly. So that's why we do it this way. Sometimes you'll see the paramedics, if they have a patient that they're pretty sure is going to code, we'll put them on this way while the patient's still awake and is able to lean forward and get them on and stuff like that, just if they have a high suspicion that the patient's going to code or not. So either way, the machine will work fine. You know, if you were to put these pads on this way, it would still work. It just needs 2 points to analyze the rhythm through. So it doesn't matter how they go on the patient. But you do want the one that, like in other words, this is the one they say to the front, this is the one they say to the back. So you do want the front and the front and the back and the back. This is the one that would be on the front. If you were changing the adult pads, this would be the one that's on the back if you were doing the adult that way. This is one specific pad for one specific type of AED, which is called the Zoll. It's a green colored one. It has a 1-piece pad, okay, not 2 separate pads, and it has a place to put your hand because it gives feedback on the rate and depth of your compressions. So this is a very specific one. I don't see too many people buying it. Most people buy the Philips now, okay, ones. And depending on which one you get, you see right on the pads, they have arrows showing you where they go in the patient's chest and everything like that, okay? This is another different Philips one. This is what they call a non-ruggedized one. It's designed to be inside, not outside. This is probably about a $2,000, $2,500 machine. It can get wet, it could be dropped. This is like a $800, $900 machine. They do the same exact thing, but it's not designed to get wet and dropped and stuff like that. I mean, it probably would do fine, but it's not tested for that, okay? This is a cartridge system where you see you could pop out and put the adult and pediatric pads in depending on which one you want to use and stuff like that, okay? So this is the, adult pads. This is the pediatric pads. You see the difference in the pictures of where they go on the patient's chest, right? So they have them both on the outer covering, and then when you take them out, they have them both on the pads. The only thing sometimes confuses people with the Philips ones is that there's one on the front of this and there's one on the back of this. So sometimes people peel this off and say, where's the other one? It's on the other side, right? So it just sometimes confuses people. Okay, to use an AED, you just need to turn it on, and it's going to talk you through every step of the way to be able to use it. Okay, and for some reason, I seem like I lost the audio. No, it's there. Okay, so again, turn it on, and it's going to guide you through every step of the way. So you don't have to worry about it. Turn you on. It's going to tell you to expose the chest, put the pads on. As soon as both pads are on, it's going to say stop CPR, analyzing, and it's going to decide whether or not it needs to shock. If it's going to need to shock, it's going to energize or light up the shock button, and it's going to say stand clear, push to shock. You have to look up and down and say, I'm clear, you're clear, everybody's clear. Make sure nobody's touching the patient before you give the shock, right? So this button will light up only when the machine decides to shock. So you cannot accidentally shock someone with an AED, okay? This is the on button on this particular one. Some of them actually turn on by opening them up, right? So they take the step of even finding the on button on. Okay, as soon as you finish shocking someone, you go right into chest compressions, right? No pause, right into chest compressions unless the patient wakes up and says what happened, okay? And again, the machine is going to keep track of, as 2 minutes, and every 2 minutes it's going to say analyzing, and it's going to see if it needs to shock again. If you don't have an AED, then you have to keep track of every 2 minutes. And approximately most people get about 5 cycles of CPR in 2 minutes, and you'll be exhausted. So after 2 minutes, you'll ask somebody else to do it for you. Okay. Again, somebody needs to ventilate, somebody needs to compress. Remember that you can only ventilate on the upstroke of compressions, right? You cannot ventilate on the downstroke. So you're going to give, you know, your 30 compressions, right? Then they're going to pause, and you're going to give 2 breaths, and then you're going to give another 30 compressions, pause, 2 breaths, and so on for 5 cycles. Okay. If the patient is not in VFib or VTAC at over 180, they could still be in cardiac arrest. If you remember to the first class we did, there's 2 other types of cardiac arrest. Pulseless electrical activity means that the electrical part of the heart is working fine. So if you were to look at the EKG, which again, you don't have any way to look at on an EMT level, you would see a totally normal EKG on the screen, but the mechanical part of the heart is not taking the signal and actually doing anything with it. So in that case, there's nothing you could do on a BLS level except good CPR and get them to the hospital. And a systole, remember the A in front of the words. So systole means squeezing. We just did that, systole and diastole a second ago, or not a second ago, an hour ago. Okay, so systole is the squeezing part of the heart. Diastole is the refilling part of the heart. Systole is the active stage. So asystole means nothing is happening, right? The heart is stopped, it's flatline, nothing is happening. Again, very rare chance of saving a patient, but if they're fresh, newly coded, we try, but on a BLS level, all you can do is oxygen, CPR, and transport. Again, in the hospital, paramedics, there's more things to do, but you know, there's not much else you could do. So, okay. So again, no shock indicated, CPR and transport. Okay, we said no interruptions for more than 10 seconds. We want to go at least 2 inches deep on the adult. Okay, on kids, they would say 1/3 the depth of, and really on adults too, 1/3 the distance of the chest, from the chest to the spine. They could also say on a child at about 2 inches. So here it's, whoops. Here it says at least 2 inches. That means greater than 2 inches. About 2 inches is around 2 inches on a child, and an infant about 1.5 inches. So you saw so far in some of the practice exams, right? There's going to be probably 10 questions on CPR, 10 questions on airway. So that's 20% of the test. That's pretty easy to, you know, score points on. You're not even getting into the thinking part of the class. This is all just memorization, right? You just have to memorize the numbers. Okay, rate of 100 to 120, that's absolutely going to be on the test, and to rotate somebody every 2 minutes. Now, they may ask it in different ways. Okay, so that's why you have to understand the English words, but all these are going to be on. Okay. Now, they can ask you on the test the New York State protocol questions, right? Because you're learning New York State rules. And I have to actually remember to send you a link to the protocol, because the protocol is like 100 and something pages. But, you know, on scene, they're going to say you're limited to 3 shocks. So that's going to be at least 6 minutes. After that, you should be transporting, okay, before you, you know, before you shock again. So they don't want people parked at the scene saying, you know, I'm going to save the patient. I'm going to stay here till I make the, you know, make the patient better, right? So this is a life-threatening emergency. We need to get the patient to the hospital. We didn't talk about, well, we actually may have talked about it with David a little bit, but hypothermic cardiac arrest. In other words, somebody fell through the ice of a frozen lake and stuff like that, okay? So there, you're limited to a maximum of 3 shocks, period, because they feel that if the heart is not responding, it's because the heart is frozen, and that they would not want you to shock anymore until the patient is brought to the hospital and they're starting to be warmed up, because the reason the shock is probably not working is that the heart is just frozen and cold, and you don't want to kind of cook the heart trying to, you know, get things stabilized. So again, 3 shocks on the scene, but if it's a hypothermic, it's 3 shocks total, right? I mean, so if you did 1 shock on the scene and start transporting, you'd only do 2 more en route. Now, if you have a save, right, if the patient begins to come back, okay, what do we need to do? We need to, I would say, I wouldn't worry about a baseline of vital vitals. I would want to know, are they breathing on their own? Okay, so you think you feel a weak pulse, patient's starting to move a little bit, are they breathing on their own? If not, you're going to ventilate them. If they are breathing on their own, you're going to put them on high concentration oxygen, okay? You may want to put them in the recovery position in case they vomit and get going to the hospital. En route, I would worry about getting vital signs. If you had a true save and the patient came back with a pulse and they're breathing on their own, or they're not breathing on their own and they're ventilating them, I would get going to the hospital. If you had a save where they actually woke up and started talking to you, you're still going to take them to the hospital, but obviously they don't need to be on their side, but they probably should get some oxygen depending on their pulse oximetry. Again, I wouldn't put them on a non-rebreather if their pulse ox is already 98% or 96% or 94%, but I put them on a nasal cannula, you know, at a liter or two. Okay. This is where we check for a pulse, right? You have a carotid artery on either side of the neck. Okay. You know, as far as problems with the AED or something like that, I have to say the AEDs are pretty much, you know, idiot proof. I mean, there's really no problems with an AED and stuff like that. Even if you were touching the patient, it would still be able to differentiate between your rhythm and the patient's rhythm. Okay. If the AED is ever having a problem, it's going to say poor pad placement. So what that means is the pad is not stuck to the patient well. So it's not that you put it in the wrong place, probably. It's going to be that it's not actually sticking to the skin well. Okay. So you have to just make sure that before you put the AEDs on, you dry the patient, the pads on, you dry the patient, you shave the patient, you do whatever you have to do so that it could stick well to the patient's chest. I've never, ever had a defibrillator not analyze a rhythm. Okay. But again, you know, I usually take the time, and I say time, a couple seconds to put it on right in the right place and stuff like that. You know, I mean, if you put them on completely backwards or something, obviously it's going to tell you because the EKG is going to be turned upside down. So it's going to say poor pad placement. In that case, you have a problem because if you only have one set of pads and you peel off the pads, they might not stick as well the second time you apply them to the patient's chest. But I've never seen that. I've never seen EMS do that. I've seen crazy things when bystanders, you know, I've seen AED pads on people's stomachs, and people have told me that the machine even said to shock. So now instead of shocking the heart, you know, they fried the person's belly. So, you know, but I've never seen EMS do that. Okay. So, you know, the problem is that the first time this happens to you, the first time you have a cardiac arrest, you're going to be nervous, scared. So again, you just go slow, you take a deep breath, and you think it through. The machine basically is designed to prevent you from hurting someone. Okay, so you want to make sure you're not in contact with the patient and no one else is in contact with the patient before you deliver the shock, okay, so that nobody else gets hurt. If anybody's holding anything that can conduct the electricity, you know, nobody should be touching the stretcher and stuff like that. You put everything kind of in the down position, right? Okay, the patient comes back with a pulse. We want to make sure they're breathing, okay? Make sure they have an airway. We don't want to, again, avoid too much oxygen. So we want to just keep their pulse ox at least 94%. I always leave the AED pads in place, even if they come back and they're talking to me. Just in case they code again, you usually only have one set of pads. So I always leave them in place. I do usually shut off the machine because if you don't shut off the machine, it keeps on talking and telling you to do things. And it may be a little distracting to the patient. So but I leave the pads in place. I leave it plugged into the machine. I leave the machine close to the patient, but I just shut it off. And if you turn it back on, it's just going to start over again. And it's just going to go back into analyze if the patient were to code again. So it's just like starting all over again. Okay, again, you have a save. So, you know, it's considered technically a critical patient. So you're going to reassess vital signs every 5 minutes. In real life, we don't do that, but you're going to be with the patient. You're going to be talking with the patient. I would, you know, in a typical transport to the hospital on, let's say, a cardiac arrest save, I would probably want to get 2 or 3 sets of vital signs if time permits. But again, vital signs don't save patients' lives. Okay, so it's more or less an information piece. So if you have to do things to keep the patient alive, you may not be able to get vital signs every 5 minutes. Okay, again, if
once you put on the monitor takes the vital signs, right? You're not taking it physically.
What was that again?
Once you put on the monitor in the patient, you put on a blood pressure cuff, the monitor takes the vital signs. You're not busy taking them physically.
Okay, remember, just be careful with depending on a machine to take your vital signs, right? It's always better. I don't have a problem like, you know, every other set of vital signs, you use an automatic machine to do it, you know, but what I'm saying is you should at least your first set and maybe every other or every third set, you should take one where you're actually touching the patient. You get a lot of information by feeling a patient's pulse. Is it strong? Is it weak? Is it regular? Is it irregular? A machine doesn't tell you if the pulse is strong, doesn't tell you the pulse is weak, doesn't tell you the pulse is regular, right? So don't get into the habit of depending on the machine. I see people putting people on pulse oxes and saying that's the patient's pulse. That's not the patient's pulse. That's the patient's heart rate. The only way you can tell a pulse is to feel the pulse, right? And the pulse gives us information. So don't get what they call, you know, machinery dependent. Don't get dependent on the machinery to tell you what to do, okay? So again, if you have a situation where the machine tells you no shock indicated, but the patient's still in cardiac arrest. It just means they're not in VFib anymore, but they could still be in systole and PEA. Again, we're striving for a pulse oximetry of 94%, right? We said that multiple times. And if you're transporting a patient in the back of an ambulance that codes or goes back into cardiac arrest, it's very hard to do CPR in a moving ambulance, because what happens is somebody has to, with one arm, grab the bar on the ceiling, and then they're only compressing with one arm. So it's not safe for the person, and the quality of the CPR is horrible. But most ambulances have, you know, the Lucas on it. There's a couple, you know, that don't, but most ambulances have the Lucas. The Lucas is a safe way of doing CPR for EMS to do, you know, in other words, for you don't have to be standing up, but it also delivers next to perfect CPR. So it really depends. I think, you know, in Ramapo, there's probably plenty of Lucases. You know, I don't think it's going to be a real, you know, issue to be able to get one. Even if the ambulance that goes there doesn't have one, usually somebody will bring one to the scene if it's a cardiac arrest. So we try not to do CPR in a moving ambulance. Again, one, because it's not very effective, and two, because it's not very safe. Okay. What else? We don't want to shock in a moving ambulance. Not that the machine can't analyze, but again, it's just a safety issue. That, you know, you don't want the driver jamming on the brakes and throwing everybody around in different directions at the same time somebody is trying to press the button to shock someone and stuff like that. Okay. So again, witness arrests in ambulances. In other words, the patient codes in front of you. Okay. Those always have a better outcome, a witness arrest, whether it's in the ambulance or in the house, because you witness them go into cardiac arrest, so you can give that first shock immediately. Or again, you could try to precordial thump and then give the shock and stuff like that. Okay. Again, we don't want to defibrillate people that are wet, because there's a possibility of the, you know, shock traveling. So if they're in any way in a wet clothing or laying in a puddle of water, try to get that clothing off them, or at least get it off their chest. If they're laying in a puddle of water, move them away from the puddle of water and stuff like that. If they're laying on like a big metal road plate, or those plates that go down to the basement of stores in the city and stuff like that, just move them off that. Okay. If you can remove any medication patches, they're on the patient's chest safely. Just remember, you have to have gloves on. So those are all things that would be nice to do. Okay. Again, implantable devices and stuff, we said as best as possible to try to avoid them, but most of the times they're out of the way automatically, so you don't have to worry about it. And there's a lot of different types of devices. We're going to go over all these different, you know, devices at some point in class and talk about them. Rockland County, you will see people with pacemakers, you'll see people with defibrillators, you'll see people with combos where they're both. As far as the LVADs and the VAD devices, the ventricular assist devices, there's a few. It's probably at any given time about 12 to 15 patients in the county about them. I usually do, again, this was not when COVID was around, but usually twice a year I teach a class at the hospital. It's open to everyone on these devices and how they pertain to what we do for patients. It's a longer, it's like, it would be, you know, a whole class, a whole night in itself. And people have cardiac bypass surgery. That's when you see that big scar that I showed you on the guy's chest. That's where instead of having angioplasty done, they actually put new blood vessels. They replace the blood vessels that are blocked with newer pieces, typically of veins that they take from the patient's leg, and they put them in place. Okay. This is the Lucas automatic CPR machine. You put this base plate, this comes off, this part comes off, you put the base plate behind them and you snap this in place over them, and this plunger comes down into CPR. This is a different one that nobody really buys anymore, where this is like the bag that inflates, and then these straps pull it and it does compression straight up and down. Either one of them, you can be using an AED at the same time you're doing the automatic CPR. Okay, so, and again, this is something that we have to, if they haven't shown you yet, we have to spend time showing you. You mean, you know, everybody has to touch it and know how to use it and everything. It's not enough to just talk about it in class or anything like that. Did they have time to show you when you were doing CPR? Did you actually?
Nope.
Nope. Okay, so I will make sure the next time they do skills that they set up one of those stations. Okay, again, once you start resuscitation, you continue until either the patient comes back or somebody else takes over for you, right? So now, it doesn't mean that if you get there and a patient is obviously dead, you know, they've been down for an hour, they have rigor mortis, they have dependent lividity, you would never start resuscitation. Or if a patient has an advanced directive, a DNR or a MOLST form or something like that, you would never start resuscitation. But, you know, terminating resuscitation in the field by EMTs requires you to call medical controls. Let's say you were, I don't know, 20 minutes into the woods and you're trying, nothing's coming back. You know, you've been working a patient 20, 30 minutes and you're not getting the patient back. You still have another hour before you're getting to the hospital. You could call medical control and explain to them, you know, it's not going anywhere. The guy's been in cardiac arrest now 30 minutes. You know, can we stop? Because the chances of bringing that patient back with an intact brain is minimal, but you need medical control's permission, okay, on an EMT level. Most EMTs don't usually terminate resuscitation and stuff like that, okay? So whatever. So it says, you know, criteria to determine when it's reasonable to stop without missing anyone. The AD did not detect a shockable rhythm and did not deliver any shocks, and you were working for the patient more than 20 minutes. So in other words, you were working in asystole arrest because the machine never shocked, and now you're going past 20, 30 minutes. Here in Rockland, you would be at the hospital, so it doesn't matter, but you know, the book is written for people all over, but that would be a time to, you know, say, okay, this is not going anywhere. This is not going to happen. Let's call medical control and ask them for permission to stop. Okay, some questions to consider.
You wouldn't know if it's an asystole or a PEA.
No, you wouldn't. You wouldn't know, but again, if it's 20, 30 minutes without a pulse, even if by some miracle that patient's saved, they're going to be brain dead, right? So you're not saving an intact, alive patient. They're going to be brain dead. I know you guys are going to say, how do you know? It could be a miracle, but that's not how medicine thinks. You know, they're saying that, you know, the likelihood of bringing that patient back in the same condition he was in prior to going into cardiac arrest is not there. So therefore, there's no purpose in resuscitating him. That's how it would think in medicine. Okay, it says, what position is best for a patient with a blood pressure 100/70 who has difficulty breathing? Okay, so you may say because it's 100/70, we should lay him flat, and that would help get more blood to his brain. But if he's having difficulty breathing, we can't lay him flat because he'll have more difficulty breathing. So we have to find the position where he's sitting up enough to feel comfortable, but he's as low back as we can to get more blood to his brain, right? So we just have to find a position where he tells us, you know, I can breathe, you know, no, I'm not having trouble breathing. Now, if he's having a blood pressure 180/90 and chest pain, then he could be sitting up, right? Because his pressure is fine. He doesn't need to lay flat. So we sit him up in whatever position he feels comfortable in, right? That's called position of comfort. So now we got a 78-year-old male, okay, who's complaining of severe shortness of breath for 20 minutes prior to your arrival. When you arrive, you find a patient unconscious and not moving. What is your immediate priority? So what do we want to know? Is he alive or is he dead, right? So we're going to do a quick, okay, check for a pulse, okay, check for any signs of life. And if there's no pulse, no signs of life, we're going to start CPR. And as quickly as possible, we're going to put the AED on them. Then if we have an additional person, they could speak to the family and get some background information. You know, what was he doing before he became unconscious? Did he have any complaints? Does he have any medical history? And so on and so on and so on. And also the important thing to ask is, does he have any advanced directives, right? Because if he has a DNR or a most form, you should not be resuscitating him. You should be stopping, okay, as soon as you find out if he had any kind of advanced directive where he put his healthcare wishes in writing before he went into cardiac arrest. Okay. Okay, so it's almost 11.
Am I going to do 2 minutes first, or am I going to do the AED right away?
So if he codes in front of you, in other words, you walked in and he's talking to you and then he codes, I would do the AED right away. If you walk in and find him in cardiac arrest, then you need to do 2 minutes of CPR before you shock him, because you want to get blood circulating to his heart, okay, to get rid of that lactic acid that built up before you shock him.
So
Okay,
why do they have on the test, the physical exam, they have that if you don't apply the AED within 90 seconds from getting the AED, then
you're talking about the skill sheets?
Yes.
I don't know. I'll just,
All the skill sheets say if you don't deliver the shock within 90 seconds of getting the AED on scene.
right, but they're probably, I think when you are tested, what they will say to you is that you have a team. In other words, they read you instructions and it says you have a team of EMTs properly doing CPR. Okay, and now you take it from here. So somebody else is doing CPR and you take it from there. So it probably says to you, you know, pause CPR, put the AED. I'm gonna have to go back and read those sheets, but you know, whatever. First of all, I gotta just tell you, you can't, don't base your thinking on sheets of paper that are written by people that you don't even know. You know what I'm saying? It's like, I hate to say it, but you know, you got people sitting in an office writing tests and writing sheets that have not treated a patient in 30 years. And you know, they're just,
I understand, but we want to pass. We don't
Yeah.
want to. It's critical. We don't want to put.
right. So on the skills, you do it the way it's on the skill sheets. And I have to tell you, I always tell the instructors, right? If the patient is treating the patient in other words, if you guys, I'm not the patient, if the EMT, the student is treating the patient the way you would be happy to see them treat your parents, God forbid, if they were laying on the ground, and it's not exactly, it's on the skill sheet, but it's the right treatment, then don't fail them. You know what I'm trying to say? In other words, it's a piece of paper, and it's not necessarily, you know, like they change these skill sheets like once every 10 years. So it may not necessarily be the most accurate, you know, piece of information. So I always tell them, I also tell all the people that are evaluating that, remember, you know, at one point you were in the other seat, right? You were the person being evaluated, and remember how nervous you were, how scared you were, you know, and so on. And, you know, just if the guy looks like he's doing it right and he forgets some little thing, you know, that's not a critical thing and stuff like that, you know, I always, like when I'm testing people, I always say to them, is there anything else you would do? You know, hint, hint, you know, like so.
I think you should come on test us.
Well, I really try. I mean, I think you've seen already that most of the people that help are not out to, you know, screw you or out to help you. So, you know, I'll give you one last funny story. I was doing a EMT class in KJ Hatzola, and one of the powers to be in KJ Hatzola decides that they're going to bring evaluators from Flatbush Hatzola up to evaluate the EMT students, because they don't know these guys, you know, they're not going to cut anybody any favors, and it's, you know, it's going to be beautiful fair. And I was like, I don't think that's a good idea. I said, you know, they've been training with the same guys time and time out. I wouldn't, you know, I wouldn't bring new people in. But anyway, on a Sunday, like 10, 15 guys from Brooklyn come up, you know, more modern guys, pretty smart guys, nice guys, everything like that. So we start doing the skills, and they're torturing the KJ guys, torturing them, asking them questions they didn't need to ask, and telling them they don't know what they're doing, and just in general not being nice. You know, so I'm going around trying to, you know, put out fires and everything. So I don't know, we're about 2 hours in. I said, okay, you know what, let's all take a break. So I don't know if you've ever seen the upstairs room in KJ Hatzola, but there's a long staircase, a very steep staircase that leads from the top to the bottom. And I always hold on when I'm going down it, right? So there's one little Flatbush guy, you know, small little guy, modern guy, you know, little wise guy. He walks out, he's going down the stairs, and he was one of the biggest pains in the butt. And one of the old time KJ guys, as his kid's walking down the stairs, takes his foot and gives him a kick and sends him flying down the stairs. And then the guy goes splat down the stairs, and everybody just walks by and walks out as this guy's laying at the bottom of the stairs. You know, I mean, he wasn't hurt, but you know, everybody just walked out. Well, after that, there was no problems. Everybody was nice to everybody else. So I was like, I guess they took care of the attitude problems and stuff like that by throwing the guy down the stairs. So after that, I always tell that story to the skills instructors and say, you know, no need to make people crazy. Remember how you did it, you know, when you were a student, and you know, don't make anybody crazy.
My father's in KJ Hatzola, and I showed him your picture that you're our instructor. He said, "Oh, he's a good guy." Yeah, that's torture.
So yeah, no, I don't believe in torturing people. So okay, so does anybody have any questions on anything before we call it a night, because it's pretty late?
Yes, there was one more thing that we discussed now.
Okay.
If we get a call on the street and they're just bystanders that are doing CPR, I don't remember where I had that question, but on one of the questions that are supposed to be on the state exam, it said that if they're doing good CPR, you let them continue do the CPR. And over here, we discussed, he said that you send them away, tell them to stop.
Tonight, I said that?
Yes.
No, I meant tell them, in other words, to stop. If they're doing good CPR, you have them stop for a second to check and see if there's a pulse. And then if they're doing good CPR, you can have them start up again. I mean, why not let them get tired? You know, everybody's going to get tired. So why not, if they're doing effective CPR, by all means, have them do CPR again. And when they pass the 2-minute mark, then you rotate them off. So it's just the problem is that most bystanders who don't know CPR do not do good CPR. But I mean, if they actually knew CPR and they were doing effective CPR, I mean, you know, we have cops all the time do CPR. You get a young, you know, young, healthy, strong cop, and he's all gung ho to do CPR. Let him do it. You know, you don't have to get tired, and you could do. I mean, remember, CPR is just a muscle activity. It's not a brain activity. So, you know, if you have to do the thinking part of it, and somebody else is going to do the skills part of it, then by all means, have them do the skill. You know, the hands-on part of it. Okay.
Frank, another question, not from the session tonight, but from those people who did the quiz, what you sent out on Thursday, did you look over how they doing?
Did I what?
If you looked over the quizzes, how they doing? I know you're getting the emails and everything.
Yes. So I mean, most of them are getting in the 70s, a few in the 80s, a couple didn't pass on the first try and took it again. But the people who passed on the first try are getting in the high 70s, low 80s, which is good. I mean, it's a long exam. It's a hard exam. So, you know, they're definitely doing okay. Somebody just asked, do I need to ask if there's a DNR? If they show up with one, then we'll stop. No. So yes, when you're going to cardiac arrest, somebody should ask the family, you know, is there a DNR or any kind of paperwork like that? We try to ask before we start, but you know, you're not going to delay starting to find the family. If you find out after you started and everything's filled out properly, then you just stop. Okay.
We have to ask before starting, or we just start, and if there is someone, if there is a DNR, the family should bring it to us. Do we have to know before we start if there is
No.
one?
So like I said, when you show up, okay, you know, you find a patient, you know, unresponsive, laying on the ground while somebody's assessing them. If the family's there, you're going to want to find out, when did they last see them? You know, is there any medical history? And then I always ask them, is there, you know, is there a DNR form? Is there any kind of paperwork where, you know, your family member put their healthcare wishes in writing so that we know what they wanted done or not done? You know, it takes 2 seconds to ask them. So again, if they say there's a DNR, but they can't produce it, then you're stuck, right? Then you have to resuscitate. Even if they tell you, yes, 100% there's a DNR, if they cannot produce it, you're stuck, and you have to, you know, you have to resuscitate the patient, or try to resuscitate the patient. Okay. Okay. Any other questions?
See you Wednesday.
Okay. So have a good night. And like we said, you know, hopefully we'll see everybody Wednesday night. Okay. Take care.
Night.
Good
I
night.
hope we're gonna have you back healthy.
I feel fine. Thank you.
That's good.
Take care.